it was being married, an unusual finding that needs to explore more, and having comorbidity. Health authorities and media have prioritized this subgroup. So the study recommends to the Ministry of Public Health and competent areas to strengthen information and education for the general population, especially those with comorbidities, intensify support for logistical and financial resources to improve vaccination coverage against COVID-19, and involve community leaders in the vaccination process. So those reference use and study, and those the field team of the survey. And we thank all the team that participate in the survey. Thank you. Obrigado.
Third presentation will be done by John, talking about the associated factors to accepting vaccination, COVID-19.
Good morning. I am presenting an abstract titled Factors Associated with Willingness to Receive COVID-19 Vaccine Among Adults in Rural Western Uganda between January to April 2022. I am John Turiagu Manawe from Makerere University School of Public Health, FETP. I had contributions from Andrew, Winfred, and Juliet of Makerere University School of Public Health. So this is the presentation outline. We are going to have the introduction, the methods, the result, the discussion, and conclusions. So
foi alvo global e desde março 2021 Uganda tem implementado a vacinação e isso depende com a produção, especialmente nas zonas rurais, onde avaliamos a vontade da pessoa para receber a vacina no distrito rural de Uganda. Assim, fizemos
On a utilisé les méthodes
between January and April 2022, whereby we did a household survey and key informant interviews. The study population were adult residents and healthcare workers participating in the COVID vaccination program. The sample size was 379 adult residents, assuming a precision of 5%, and also assuming normal distribution and randomness. So we also had 8 key informant health workers at Hoima Regional Referral Hospital who were participating in the COVID vaccination program. The sampling technique for the quantitative arm, it was random multi-stage sampling.
onde selecionamos paróquias, aldeias e escolas e as casas e consideramos o líder ou o mais velho naquela casa. Então só foi
we did purposive. The health workers who were participating in the COVID vaccination program, and the ones who had actually treated patients during the first wave, they were considered purposively, and they would identify the subsequent health workers to be interviewed by snowball method until when we achieved redundancy. So data collection for the quantitative arm, we used a structured questionnaire whereby participants self-reported on willingness to receive the vaccine by answering a yes or a no, and also on other factors such as the demographics and the other factors like distance and so on. So for the qualitative arm, we used a key informant guide. Data analysis. In the quantitative, we assessed the level of willingness. We presented it with frequencies and percentages. And the factors that are associated, we did univariate analysis to obtain crude prevalence ratios and p-values. Then the factors that were significant at univariate level, they were taken to multivariate analysis to obtain adjusted p-values and prevalence ratios and confidence intervals. For the qualitative arm, we used a thematic approach whereby we got statements, themes to get the subjective meanings. These are our results. All the 379 participants had heard about COVID-19 vaccination, and the commonest source of information were hearing it on the radio, adverts and announcements and programs, hearing it from the friends in their social circles, and some of them from the health workers. They got counseling, those percentages reflected. And overall, the level of willingness was at 71%. So this table shows the factors that are associated with willingness to receive COVID-19 vaccine. So we can see that willingness was significantly higher among people who had tertiary level of education with adjusted prevalence ratio of 1.2 and 95% confidence interval of 1.1 to 1.4 and a p-value of 0.03. More so, people who resided within less than 5 kilometers from the health facility, because the health facilities were the vaccination posts at the time. They were 1.2 times more likely, they're more willing to receive the vaccine with a 95% confidence interval of 1.1 to 1.3 and a p-value of 0.04. So the participants who had heard about the vaccination from the health workers were significantly more willing at adjusted prevalence ratio of 1.3, 95% confidence interval of 1.2 to 1.6, and finally, those participants that perceived health workers to be friendly, they were more willing at adjusted prevalence ratio of 1.2, 95% confidence interval 1.0 to 1.4, and a p-value of 0.04. From the qualitative arm of the study, perceived fear of loss of libido and infertility was a major concern across interviews, and that bad willingness. As we can see from the quote of one of the key informants, when COVID-19 vaccination came, people were saying that actually if they vaccinate you, in the long run, you may fail to produce, or it may burn sperms in men. They are worried that they will not function in bed after the vaccination. So conclusion, willingness to receive the COVID-19 vaccination was high in rural setting, but safety concerns were a main barrier. And therefore, strategies to improve COVID-19 vaccination programs in rural settings may focus on bringing the vaccine closer to the people via campaign mode or outreaches and health education messages through local radio stations to counter fears on reproduction and misconception about the vaccine. So these are some of the measures that were actually implemented to have us get better success. I acknowledge the people who participated in this study listed here, and I thank you for listening to me.
La quatrième présentation va faire par...
The fourth presentation will be made by Ahmed from Ghana, and it's on the determinants of vaccination against COVID-19.
Good morning, ladies and gentlemen. All fine. Okay. I'm Ahmed Hudatu, and I'm presenting on determinants of COVID-19 vaccine among senior high school students in the Okahao municipality. COVID-19 vaccine has prevented more than COVID-19 vaccine has prevented more than 19 million deaths. Despite global efforts put in place, Africa still records low COVID-19 vaccination coverage. Ghana set a target of vaccinating at least 20 million. As at September 2023, Ghana has been able to vaccinate 11 million. In the Okahao municipality, more than half of the COVID-19 cases reported were among senior high school students, and this can affect their health and academic outcomes. Understanding COVID-19 vaccine uptake among students can help develop target interventions, which can increase vaccine uptake and reduce COVID-19 complications. Based on this, we assess level of COVID-19 vaccination uptake among senior high school students and its associated factors. We employed a cross-sectional study among senior high school students in four senior high schools in the Okahao municipality. We use an estimated sample size of 420, and we arrived at this sample size by using the Cochrane formula or the single population proportion formula. A multi-say sampling technique was used to sample the participants, and a structured questionnaire was used to interview the participants. For the variables assessed, social demographic characteristics such as the age and sex, person-related factors such as history of COVID-19 infection, the health belief model construct. We adopted the health belief model construct. The health belief model construct just explains an individual's belief of the threat of contracting COVID-19 vaccination and the belief on the effectiveness of the COVID-19 vaccination. So it actually explains the likelihood of an individual vaccinating based on his or her belief. For the data analysis, the level of COVID-19 vaccine was assessed using the proportion of students who had received at least one dose. And for the determinants, variables were, we ran a logistic regression for the variables, and the variables with that p-values less than 0.05 were considered statistically significant, and these were the determinants of COVID-19 vaccine uptake. For this figure, among the students, 57% of the students had received at least one dose. Surprisingly, 97% among the individuals had received at least one dose. Surprisingly, individuals who had received at least one dose we found that 97% of these individuals had fully vaccinated. Association between social-demographic characteristics and COVID-19 uptake. We found that age group and program of study were statistically significant. For the association between person-related factors and COVID-19 vaccine uptake, the history of COVID-19 infection and the attitude of COVID-19 vaccination were statistically significant. Moving to the association between the health belief model construct and the COVID-19 vaccine uptake, perceived benefit score. So individuals who recorded a high perceived benefit score were more likely to take the COVID-19, or individuals who had a high perceived benefit score were more likely to take the COVID-19 vaccine. And individuals who had a low perceived benefit score were more likely to take the COVID-19 vaccine. And individuals who had vaccinated recorded a high self-efficacy score. For the determinants of COVID-19 vaccine uptake among SHS students, the program, which is technical and home econs. So students who study technical and home econs had a higher odds of being vaccinated as compared to students who studied general arts. For the so we found perceived benefits, perceived barriers, and self-efficacy should also be a determinant of COVID-19 vaccine uptake. So a 1 unit increase in the perceived benefit score can increase 7%. Sorry. So the perceived benefits, perceived barriers, and self-efficacy were found to be determinants of COVID-19 vaccine uptake. The level of COVID-19 vaccine uptake was 56.7%, and a study conducted in Zambia and Ghana recorded a lower vaccine uptake. However, a study conducted in China recorded a higher vaccine uptake, and this could be attributed to the fact that the students wanted to take the J&J vaccine, which is the Johnson & Johnson, as it's a single dose. They didn't want to go through the pain of taking another dose to be fully vaccinated. And the determinants of COVID-19 vaccine uptake, the program of study, which is technical and home econs. So we further analyzed the data, and we found that more than 50% of the students who reported experiencing COVID-19 offered this program. And this could have increased their higher perceived susceptibility. A study conducted by Limbu and also a study conducted in Hong Kong also found perceived barriers, perceived benefits, and perceived susceptibility as determinants of COVID-19 vaccine uptake. In conclusion, COVID-19 vaccine uptake was moderately high. Determinants that influenced COVID-19 vaccine uptake included the students' program, perceived benefits, perceived barriers, and self-efficacy. We recommended that Ghana Health Service, in collaboration with Ghana Education Service, implement targeted awareness campaigns emphasizing the benefits of COVID-19 vaccination, address perceived barriers, foster self-efficacy by offering clear guidance and support. Also, for the public health action implemented, I presented my findings with the district health management team, and before I came for this presentation, I called them, and there has been an improvement in the COVID-19 vaccine uptake among the students. Thank you.
La dernière présentation va être faite par...
The last presentation will be made by Shaza. He is going to present us the factors associated with the weak or the low vaccination coverage in the area of Mwanza in Tanzania.
My name is Dikilan Chadza from Malawi. I'll be presenting on exploration of causes contributing to low COVID vaccine coverage in Mwanza from March 2021 to December 2022. That's my presentation outline. We all know and appreciate that COVID vaccine is safer and builds immune response, such that vaccination is a crucial intervention to reduce the effects of the pandemic. Therefore, globally, it was agreed and targets were set as projected that by September 2022, nations had to vaccinate at least 30% of their population. And then by December 2022, at least 50% of their population. The table that you're seeing shows vaccination coverage in Mwanza amongst the three facilities under study. We have the district hospital, which had vaccinated 32.8% and then fully immunized 13.1%. And Tambani had vaccinated 37% and the fully immunized were 16%. And Kunene Gude had vaccinated 56.7% and the fully immunized amongst their population was 20.3%. That brings us to the problem of the statement, that nationally it was agreed that the target for during the period of study was to be, the vaccination performance was to be 50%. And the facility under study, which happens to be Mwanza District Hospital, had a coverage of 32. And then that is against the set 50, and the fully immunized of 13.1%. That already being the district hospital had the lowest performance in the vaccination. That now led to the objectives of the study where we wanted to identify the root causes that had to lead to the low uptake of the vaccine, as well as identify the critical cause which could have been dealt, possibly could help in the uptake of the vaccine, and try to draw a map way forward. The methods that were employed in the study was basically to data review and then literature review. We also did focus group discussions with the primary vaccinators and their immediate supervisors. And then the data was analyzed using fishbone diagram to identify the tipping and the critical cause. On your screen, you're able to see the fishbone and its tipping explanation. TPN is T stands for totally within control, and P stands for partially within control, and N is not within control, whilst the CC is critical cause. Therefore, that's what we established and found out that we had 4 categories of the factors to do with vaccines and then to do with staff and also do with the administration of the service as well as the target population. As you're seeing, a lot of factors here were to do with the staff. On the staff, you see inadequate knowledge, which was also under total control. And on the target population, you could also see there was underestimation of the target population, which was an issue to do with the staff. And among administration of the services, we have low second dose follow-up, as well as inadequate supervision, which tend to be the critical cause. Summary of the findings, we've seen that factors that were within control was about 36%, and then those that were partially within control, 63%. And none was not within control. Such the case, we identified inadequate supervision as the critical cause because it was so inconsistent. On my discussions, we find that low uptake emanated from different sources amongst the factors and the categories that were being beamed. And more root causes are under staff control, which now is able to tell us that that can partly be the vaccine uptake can partly be improved. Inadequate supervision was identified, as I said, as a critical cause. It was totally under control. And then we developed an action plan that was presented to the district health office with assigned responsibilities to help improve the uptake. In conclusion, we would want to say inadequate supervision is critical cause of the low vaccine uptake in Mwanza, whereby, when you have effective supervision, it will be able to motivate the staff and enhance professional practice, thereby resolve administration hitches in the delivery of the service, and then also clarify issues, roles, and actions that the primary vaccinators needed to do so as to increase the uptake. Such being the case, we really believed that the increased vaccine uptake was very possible. Then we recommended to the Director of Health and Social Services in the district to ensure that quality supervision of health HSCs, who are the primary vaccinators, was enhanced, as well as intensifying involvement with local and religious leaders in the community mobilization. The following are my references that were used in the study, and such is my acknowledgements. Mr. Daniel Mapemba and Madam Grace Funsan, who also happens to be here. She's my mentor. I thank you so much.
Merci. On vient de finir les présentations.
Thank you very much. We have finished the 5 presentations which have been made. The first presentation was made by the colleague from Nigeria, which was on participation of COVID among the saloon dealers, and vaccination uptake was higher. The second presentation was made by a colleague from Guinea-Bissau on uptake of vaccination and vaccination coverage, and 41% of vaccination coverage was related to the first dose. The third presentation was made by John from Uganda on factors associated. And so for that, 71% of uptake was found. In Ghana, our colleague made a presentation, uptake determinants and the perception of advantages among students. And we found that amongst science students, uptake was higher than among the arts students. So now, this is the question-answer session we are going to start. We shall take 5 questions, and when you want to ask questions, please tell us to whom your question is addressed and be very precise.
C'est une seule question par intervenant. On commence par cet étranger. Allez-y.
One question per person, so please take your microphone.
Merci. Excusez-moi. Merci, je suis...
Thank you very much. I'm Dr. Bongo from Gabo. I'm an epidemiologist. So I want to congratulate all the presenters. These were very high-quality studies. I'm pleased. So I don't want to talk about the methodology. And my question is to Nigeria and Guinea-Bissau. I'd like to know, because you did use analytic studies with association measures. So I simply would like to know, because within your methodology, I didn't see. So I wanted to know, how did you normalize your data? And I want to know, did you do some adjustment? And what were the adjustment factors? Because when we saw for the case of Ghana and Uganda, they specified the model, but in the presentation of Nigeria and Guinea-Bissau, I didn't see those elements, even though we know that you use multivariate analysis. But I think it will be nice to specify the methodology, which model did you use? And I would like to know if your data has been normalized, because when I'm asking this question because of value P. That's why I would like to have the answer on the normalization of the data.
Oui, allez-y.
Thank you very much. And I would like to thank the presenters for the fantastic job, and to thank the conference organizers for giving chance to the really early career phase investigators to present their work. Now, although COVID-19 vaccines are highly effective at preventing serious adverse events, including mortality, I don't think we have strong evidence to show that they actually reduce the risk of acquisition of COVID or reduce the risk of actually being infected with COVID. And my question to all the presenters who have talked about low uptake of COVID, especially among the populations with low risk of mortality, do you think the public health approach of universal vaccination to prevent transmission was an evidence-based public health approach? Thank you.
Et votre question, c'était adressée à qui? C'est général?
To whom did you ask your question? Use your mic.
Thank you. Mine is a comment and a question made to the Ugandan presenter. I wanted to make a comment about our experience in Tanzania, where we really had initial a lot of hesitancy to COVID-19, and we had to go back to the drawing board. And one of the things that we did was to understand that COVID vaccine was unusual because you were targeting adults, which is not usually the case, and you are also targeting people who are not sick, meaning you have to convince somebody out of their way to go and get vaccinated. So what we had to do was do what we call the demedicalizing the vaccination. Take the vaccination to the people where they are, take it to the communities, set up vaccination units where people live or where they are operating their businesses. So we did not find, after that, we did not find the resistance to be hard. People just needed a little more information, address the disinformation, and then take the vaccination to them rather than expect them to go to a health facility. And that is what really helped us with Tanzania, where we actually reached 70% of the target population of people above 18 by December 2022. So I was just wondering whether you used that kind of intervention in the Uganda rural population. Thank you.
Il y a encore une main? Bon, on va donner la parole aux intervenants de pouvoir répondre.
We are going to give the floor to the presenters to answer to these three questions.
Okay, muito obrigado.
Thank you very much. That shows that you are very attentive to the work that I presented. Now, talking about what Ngombo said, I don't know if I pronounced very well your name. How many adjustment factors that we use in our methodology. Now, for adjustments, as we did that, I said 30% as a less than 5. That has been substituted by another agglomeration from 5 to 6 interviewed. Now we did the adjustment. Now that adjustment is equal to the number of people who attended, and also
the number of persons who have been reached. That is the only question that I have to answer to. Thank you.
It shows we are following what we discussed, and we appreciate that. I think the adjustment factors was also addressed to me. I need to emphasize at this point that we use a simple random sampling, so we did not use any complex sampling methodology. We have the sample frame because they have a trade union where they register all the hairstylists. So we got the sample frame from there, and after calculating our sample size, we use computer-generated number to randomly select the sample number. So we did not use complex sampling, and it does not involve sampling factor. Concerning the model, our emphasis here is on perceived risk. So we use the extended parallel model, and we focused on the perceived risk component. We use the Likert scale, just like it was done. I think that's all the question for me. Thank you.
Okay, I'm John from Uganda, and our colleague from Tanzania is talking about demedicalizing, taking the vaccine to the people, and so on. So if you paid attention to our recommendations, okay, from our findings, the findings showed that people who were residing within less than 5 kilometers from the health facility, at that time, we were still running facility-based vaccination. So from this study, we found that people who were actually far, they were not willing to come for the vaccine. And it is one of our recommendations to change the mode to the campaign mode and outreach mode, which was actually done later in the implementation of the COVID vaccination by the Ugandan government. So the question whether we demedicalized and took it to the people, yes, eventually that's what we did, and we saw a lot of improvement in the program. Thank you.
Okay, we would like to conclude at this point due to, sorry, there's a question?
Hello, yes, thank you very much. And my question is directed to Ahmed from Ghana. I believe every study comes with limitations, so I would like to know what one limitation we could consider while interpreting the findings. Thank you very much.
Thank you very much for the question. Okay, so one of the limitations was self-reporting bias. So the vaccination status, we assess this subjectively. The individuals could have lied, and then for also if the history of COVID-19 vaccination too, we didn't have any evidence to back if the students had actually had been infected with COVID-19. Thank you.
Yes, there is a concern which has not been responded to, whether it was an evidence-based public health approach to roll out vaccination to the general population, irrespective of the risk categories, whether you have comorbidities, hypertension, diabetes, old age, very young, and so on. I would say it was an evidence-based approach. First of all, during the second wave of the pandemic, we saw a lot of mortalities, and there was a lot of unknowns about the COVID-19 pandemic. And some of those mortalities that we experienced were among people who didn't even have these other risk factors, the comorbidities and extremes of age. And people actually, even the ones who survived the disease, they are living with bad sequelae of the disease. And we know that, yes, the vaccine was not preventing you catching the virus, as some people misunderstood it. The purpose of the vaccine was to prevent you from getting the severe form of the disease. So that means you'd get less complications and you'd have less chances of dying. That was the goal. So I would say it was an evidence-based and well-thought public health intervention to control the pandemic.
Yeah, that's a good wrap-up from our colleagues. And I would like us to give them a big round of applause for the nice presentations they've done. And in essence of time, would like to briefly say thank you and welcome the next session, because we've actually eaten into like half an hour of their time. Yeah. Thank you very much for attending this session.
You met physically, I think we were talking with the Linda, right? Yes, I have. Okay, so there's a session. I mean, the oral presentation, right?
Yes, this is the oral posters.
There are 4, right?
There's 6. Oh, yeah, you're the evaluator?
Hey, sorry, is this one?
Oh, no, this is a... yes, you're here. Oh, you're not evaluator.
Yes, I'm the room manager.
Oh, the room manager. Okay, perfect. Yes, so we have 6.
Okay, we have to finish by 10 o'clock now, Plenary.
I mean, we can't finish by 10 because that's only 14 minutes away. We're delayed.
No.
So we have, the session is allotted 45 minutes, so I would like to keep to that 45 minutes.
So I think just call the presenters coming.
Yeah, and do we have a timekeeper?
The evaluators coming, right?
Are the evaluators here? Hi.
So what we'll do, this room is going to be used for plenary,
yeah.
so let's try to
I want to keep it.
up.
Yeah.
Patch it up.
Yeah. I think I'll do everyone will get 5 minutes to present, one question, and then next presenter.
So we take questions, I think, at the end of all of the presenters.
I thought it might be faster if we could just do one question after every poster.
Yes. So congratulations, session 2 and 3. Okay, we have...
Good morning. Could I have the presenters please come on the stage? This is the poster session 2. If you are one of the presenters, can you please come up on the stage? So I'm hoping that my plan is everyone will come up,
Yeah,
do their 5-minute presentation.
Yes. So we
one
can,
question, and we move on to the next. I think that'll be faster than.
do we have Fatima Ahmed Haida? Please come up. Dan Assis Sadan, come up. Alimayahu Abebe, Karen Inotila, and another big name here, Biemeno Tuafin Dana. And then that's Tao Asefa. Please come up. Are we in the room? Do we have them here? Poster presentation, do we have those names here?
And are the evaluators in the room? I'm looking for Celestine Ama. Great, great. And then I'm also looking for Ernest Konadu. Great, thank you. Great, we have our evaluators. Oh, here's some presenters.
Have two here.
Okay, so we have 2 presenters. Are there any of the other 4 presenters in the room? I'm looking for Fatima Ahmed Hadir. If you're in the room, could you please come to the front? I'm also looking for Dam Aziz Sudan. If you're in the room, could you please come up? Mameno Twafinda, let me get this name wrong. Well, people know if they're presenting. And Desta Asifa Gabizi. So maybe we just have to start with the 2 that we have. Okay.
Struggling to pronounce.
I was struggling. Thank you so much. Okay, so we have 3. We have 3. Okay. Yeah. Okay. And then who's in charge of bringing the presentation up? You will? Okay. Good morning. In the interest of time, we're going to go ahead and get started. I realize we only have 3 of our presenters, but I'm hopeful that the other 3 will come in the room. I think we're just having, some of the rooms are starting at different times, so they might be in another room right now. The way we're going to run this session, this is an oral poster session. So every presenter has 5 minutes to do their poster, and then we're going to do 1 question. And I realize there might be a lot of questions, but we have the plenary session is coming up in this room next, so we do need to keep this on schedule. So we'll do the 5-minute poster presentation, 1 question, and then we'll move on to the next presenter. So having said that, I think we will start with the first presentation. We will start with Alamehu, and I'm sorry if I'm mispronouncing your name. This is a presentation of the Pertussis outbreak investigation in Beyida Werida, North Gondar Zone, Amhara region, Ethiopia, case control study, March 2022. show 1 minute and no time.
Good morning and thank you. I'm Alemaya Baba from Ethiopia. I'm going to present a Pertussis outbreak investigation in Amhara regional state of Ethiopia. So as an introduction, whooping cough of Pertussis is highly contagious bacterial disease, which is transmitted through respiratory tract infection, and its main cause is bacteria, which are called Bordetella pertussis and Parapertussis. So despite widespread pertussis immunization and despite the widespread pertussis immunization childhood, there are an estimated 50 million cases and 300,000 deaths due to pertussis globally each year. Pertussis typically has three clinical stages: the catarrhal, paroxysmal, and whooping stage. The classic symptoms are seen more often in unimmunized children. Also, pertussis is mandatory notifiable disease in most countries. There is significant underreporting, especially in adolescents and adults. Following the COVID-19 pandemic and the internal conflicts that happened in Ethiopia, the local health system was compromised and many of health facilities were destroyed and become out of service. So the objective of our outbreak investigation was to describe the burden of the pertussis case and to identify risk factors associated with the outbreak and also to take appropriate public health intervention. So in methods we used, investigation was conducted in Bayeda district, which is found under Amhara regional state. And the district is one of the hard to reach area in the region, with a difficult geographical landscape. The descriptive analysis was conducted, followed by unmatched case control study with 1:2 ratio, data collection tools. We reviewed outpatient medical records that are found at a health facility level, and we also discussed with key informants and with health professionals that were providing health service under that specific area, and also cases and controls were interviewed using structured questionnaires. So we analyzed data using the SPSS version 20. Before that, we entered those collected data into APM4 version 7.24 version. So we used CDC's case definition to identify those cases. So the suspected case of pertussis is non-improving cough of 40 days and more duration. And also we use also the epidemiological linkage to identify those cases, and also confirmed cases where cases are laboratorically confirmed. And also to confirm the existence of the outbreak, 10 nasopharyngeal swab samples were taken to National Laboratory Institute, and out of those 10, 6 of them were found to be positive for Bordetella pertussis. So when it comes to result, we identified 60 pertussis cases in the 2 days with case fatality rate of 3.3%. The mean age of the case were 11.4 years. Out of 58 interviewed patients, around 60% of them were men, and out of 116 controls, 62% of them were men. Around 83% of cases didn't receive pertussis containing vaccine. 79% of cases had history of contacts with confirmed cases, and overall attack rate was higher in male compared to female. 6 of the 10 samples I have already stated were positive for Bordetella pertussis. When we come to description by place, all cases were reported from 2 villages which are found under Luare Health Cluster, and health facilities those found around those cluster were lacked refrigerator and power for conserving vaccines and other medical supplies. Description by time onset of the symptom occurred between January 30 and March 7. And 36 days duration of pertussis outbreak occurred in this pertussis outbreak. Multivariate analysis was used to identify those associated risk factors with this outbreak. And also public health interventions were taken. Among those interventions to manage cases and strengthen the surveillance system effort, training was provided at on-site, health education was given for the local community, and home-to-home treatment was provided, and solar refrigerator was also provided by zonal health departments. This is a picture when we are conducting health education. So, conclusion and recommendation, we conclude that there were late identification and notification of cases, and vaccination status, awareness or mode of prevention of pertussis, housing condition were significantly associated with pertussis outbreak. Absence of infrastructures like road and power also has worsening the outbreak. We recommend to improve vaccination status of the village, and the community awareness should be strengthened. And also we recommend to strengthen the surveillance system of that specific area. Thank you very much.
Thank you so much. Can we have one question, please? Who would like to be the lucky questioner? Yes, over here. Is there a microphone? I think he's coming.
Okay. Thank you. Congratulations for your presentation. I saw in your conclusion and your finding that the outbreak has been detected very late. What are you doing now and then to prevent late detection for the future pertussis outbreak or any future outbreak in the area where you conduct this outbreak investigation?
Is on now.
Okay.
Thank you for your question. There was late identification of the outbreak. This was of during the outbreak time, there were conflicts in that specific area. As you remember, there were a conflict in Ethiopia between the regional state of Tigray and the federal government. That makes restriction to move in that specific area and to intervene. But now it has already, situations are already cleared, and things are going well now. That is the reason why the investigation and notification was delayed.
That should be great, thank you. Our next presentation is Karen, and it is clusters of mumps cases in schools in Omaruru district, Irango region, Namibia, February 2023.
Good morning, everyone. My name is Karen Shekuja from Namibia, presenting a cluster of mumps cases in the schools in Omaruru District, Erongo region, January to February 2023. Well, mumps is a contagious, vaccine-preventable disease presenting with inflammation of lymph nodes, salivary gland, and eventually the central nervous system. It's transmitted via direct contact with respiratory fluids and household fomites. According to WHO, about 500,000 cases are reported annually. However, due to lack of proper surveillance system in Africa, we have a lack of published data on the disease burden in the continent. Between 2022 to 2023, Namibia have reported about 15,000 cases, of which 1,027 were from Erongo region. So in EPID week 2 of 2023, we observed an increase in cases reported from schools. This prompted an investigation to investigate the disease burden, to apply control measures, and interrupt transmission. We conducted a descriptive cross-sectional study in Omaruru district, and this is the map of Namibia showing where Omaruru is located in Erongo region, which have a population of about 21,200, of which 6,100 are under 15 years. We conducted active cases in 5 reporting schools, or using a line list to collect demographic, clinical, risk factors, and vaccine status. We also did some environmental and knowledge assessment. We calculated a sample size of 107 using the Dobson formula. So for this investigation, we define a case as any learner with unilateral or bilateral swelling of parotid gland in Omaruru district between January and February 2023. We analyze our data using Microsoft Excel to calculate frequencies and proportions, and we obtain some permission from the school management as part of ethical consideration. Now, ladies and gentlemen, our findings are as follows. Of 143 cases reported, about 87% of them were reported from schools, of which 59% were male with a mean age of 8. This is a distribution of cases according to the age group, and age 5 to 9 contributed to about 80% of all cases. We collected some blood sample for laboratory confirmation, and after 5 confirmed cases, we started epi-linking. We calculated an attack rate of 2.3, and fortunately during this period, there was no admission or mortality reported. We found that only 47% of learners have knowledge on mumps. Now, this is the distribution of cases according to the schools, and we see that Okongwe and Pahe Primary School account to a total of about 75% of all cases, and I should indicate these are bonding schools. Each learner misses about 4 school days during recovery, and none of these cases were vaccinated against mumps. This is the EPI curve showing the distribution of cases from EPID week 1 to 11 of 2023. On environmental assessment, we found that the school hostels were overcrowded, there was no isolation at schools, and there was no sufficient water point for frequent hand washing. And we found that some classrooms, especially the one made of corrugated iron sheets, were having poor ventilation. So we found that indeed the outbreak affect school-going children, and then this is consistent with a study done in Asia. We found that learners were missing school during recovery, and overcrowding of hostels was found to be hindering implementation of control measures. We acknowledge that the study is limited to lack of transport to be able to reach out to all the schools in the district, and thus we recommend that the Ministry of Health introduce mumps containing vaccines and print out enough IEC materials to address the knowledge gap. We also request that the school reprioritize some of the rooms for isolation, and at least schools to set up TP taps. We also recommend that the district transport office to prioritize surveillance in transport arrangements. As part of our action, we isolated and treated the cases. Health education was given at schools. We assisted the schools to set up TP taps. We printed and distributed some IEC materials, and this finding was shared with the district health management team. With that being said, ladies and gentlemen, thank you so much.
Thank you so much. Can we have a question, please? Yes. I think the microphone.
Thank you very much for the presentation. My question is very simple. You only indicated that you asked the permission from the school. What are other ethical considerations for this case? Thank you very much.
Thank you so much for the question. We indeed obtained permission from the school management, but we also get permission like from the learners themselves, like verbal informed consent. We ask them for that permission to be able to conduct this investigation and ask them those questions. Thank you.
Thank you. We'll move on to our next presentation. This is from, and I'm apologizing, I'm mispronouncing these names, Mimino Ginamwami. And the title of the presentation is "An Analysis of a Surge of Mumps Suspected Cases in Okahao District, Amusati Region, Namibia, January to February 2023, a case for mumps vaccination."
Ladies and gentlemen, good morning. My name is Meameno Nginamwami from Namibia FUTP, presenting to you an analysis of a surge of mumps suspected cases in Okahao District, Umsati Region, Namibia, January to February 2023. Mumps is a viral infectious disease that causes the swelling of parotid glands. Here is a physical presentation of mumps. It is vaccine preventable that leads to serious complications such as encephalitis, viral meningitis, orchitis, and deafness. Globally, over 200,000 cases were reported in 2021, where sub-Saharan Africa, including Namibia, has a major share of these cases. Mumps is not included in the expanded program on immunization of Namibia, and it has not been a priority disease in the country. Consequently, the surge of mumps cases prompted its inclusion in the Integrated Disease Surveillance Weekly Reporting. However, I must mention that mumps vaccine can be given at private health facilities in the country. Early March 2023, Okahao District reported an elevated number of mumps suspected cases. We therefore characterized mumps cases in Okahao District by person, place, and time. For methods, we have conducted a secondary descriptive data analysis in Okahao District with an estimation population of over 38,000 individuals, where 40% of the population is under 15 years. Data was received in Microsoft Excel. It was cleaned and coded and exported into EpiInfo for analysis. We generated frequencies and proportions and presented the findings in in tables and figures. Here is a map of Namibia indicating where Umsati region, in which Okahao District is. Results: a total of 67 mumps suspected cases were recorded with a median age of 8 years. This table shows the distribution of mumps cases by age, sex in Okahao District, where 56.7% of cases were recorded in the age group of 5 to 9, and 55.2% were recorded in the female sex. The EPI curve shows that in EPI week 5, 20 cases were reported, EPI week 5 of 2023. Of the total 67 suspected cases, 12 saliva samples were sent to the laboratory for analysis. where 11 came out positive for IgM, giving a positivity rate of 91.7%. A total of 65 cases were not vaccinated, and we recorded no mortality. The distribution of reporting health facilities in the district: Okahao Clinic reported 44 of the cases, and Nindirangadi and America Clinic reporting 1 each. This is a distribution of mumps cases by villages in Okahao district from January to February 2023. Limitations and conclusions. Only the data from our public health facilities was used in this analysis, and we have observed that there is a lack of mumps-specific data collection tool. In conclusion, this analysis confirmed an ongoing mumps infection in Okahao district, which affected mostly pupils in the age group of 5 to 9 years. These findings aligned with the results of investigations conducted in Omaruru district of Erongo region in Namibia, as well as studies undertaken in South Africa and Zambia. Majority of cases were not vaccinated, where most of the cases were reported in the health facility in Okahao town, which possibly could indicate that individuals in towns have accessibility to healthcare services. We recommend surveillance focal persons to intensify mumps awareness by community healthcare. We recommend that surveillance focal persons intensify mumps surveillance system efforts, as well as community healthcare workers in the district to enhance health education and public awareness to the community. We also recommend the implementation of mumps-specific data collection tool by Ministry of Health and Social Services, as well as this study to serve as an advocate for introduction and incorporation of mumps vaccine in Namibia EPI. For public health actions, we have given health education to 68 learners, 18 teachers, and 28 parents. This is just a visual aid of when we were in the field giving health education. We advocated for the enhancement of mumps surveillance to ensure adequate data to support the need for the incorporation of mumps vaccine in the Namibia's EPI. There is also an ongoing of mumps monitoring cases, which is done through weekly integrated disease surveillance and response, as well as ongoing raising of public awareness through different platforms by community healthcare workers, as well as outreach services. Thank you. Here are my references.
Thank you so much. We'll do one question, and while you're thinking of your question, I would like to ask if the other three presenters are here for this session. If you are here, can you please come to the front? So I'm looking for Fatima Hadir, Dam Sadan, and Desta Gobizi. If you are in the room, please come to the front. Yes, please.
Thank you. Carl Reddy from AFENET. I just wanted to confirm with the last speaker, it's a comment and a question. You know, Namibia's health system in the past was modeled closely on South Africa's health system. They shared a lot in common. So was mumps never part of the MM? Thank you.
So we were supposed to have 6 posters today. We've had 3 wonderful poster presentations so far. Are there any of the other 3 presenters in the room? Otherwise, we will have to wrap up this session. It'd be great if the other 3, I'd love to see these other 3 posters. Not seeing anyone coming up. Well, I would like to thank the 3 presenters. You guys did amazing. I love seeing these posters. Congratulations. Can we give a round of applause? Thank you so much.
come here and talk. has been declared over. And it's also typically only applied for larger scale outbreaks. And so we ask ourselves, if every public health event is an opportunity to improve and to learn, then what about those that don't trigger an intra-action review or an after-action review? And what can we do to learn from the event and improve the response in real time instead of waiting until it's over or nearly over? This is where 717 comes in. So the 717 target is now adopted and is the bedrock of the new normative guidance from the World Health Organization on early action reviews. These early action reviews using 717 create an important opportunity for real-time and rapid performance improvement in the earliest phases of a suspected outbreak. So, how does it work? There are different approaches to implementing 717. There's a real-time review of a single event, which is your typical implementation for rapid performance improvement. You have a retrospective review of a single event, which can be complementary to an after-action review. And you also have the retrospective review of multiple events. So this last one comes from the idea that if your country is interested in adopting 717, you shouldn't have to sit around and wait for an outbreak to happen to start using it. So what we've seen many countries do, and it's proven to be very valuable, is when 717 is adopted, one of the first things you do is collect historical outbreak data from outbreaks that have happened over the last 6 months, 12 months, 18, 24 months, and do an assessment on those outbreaks in aggregate. And this will help you to identify some of the common bottlenecks, the common constraints, so that you can begin to address those immediately without having to wait for an outbreak to occur. But regardless of which three of these implementations you opt for, and they're not mutually exclusive, it's usually some combination of all of them depending on the nature of the context, the steps are more or less the same. We're capturing timeliness data. We're using that to calculate 717 performance. We're using that 717 performance to conduct a bottleneck analysis and identify gaps, and then identifying and implementing corrective actions to those. So let's look at a real example. We have my colleague Lydia here from Uganda, who is an absolute expert in this. Uganda, and I'm sure many other colleagues here from Uganda were a part of 717 as well. Uganda was one of our earliest adopting countries, implementing 717 and piloting it starting over 2 years ago. So when the Sudan Ebola virus outbreak occurred in Uganda, the 717 approach was used to assess and improve the response during the response. It's a little difficult to see this slide, so I hope you have the opportunity to review it when you receive a copy. But essentially, the 717 found that it took 46 days to detect the outbreak, less than 1 day to notify, and 9 days to mount an effective early response. So they found that the largest delays were from outbreak detection, and there were some additional delays on the response as well. So they conducted a bottleneck analysis to get to the root cause of these delays, and they identified enablers to the system, and they suggested corrective actions. Based on this analysis in Uganda, during the outbreak, the government was able to quickly identify partners with available funds to reduce delays in accessing rapid response team funds for contact tracing, and also identified new buildings for an isolation unit, since the previous infrastructure was deemed to be inadequate. They also identified a longer-term priority, which was to increase IDSR training, specifically at private facilities. So this example from Uganda demonstrates how 717 can be used for rapid performance improvement. But we've also found that it can be a very effective tool for prioritization, for financing and system strengthening initiatives, for communication and advocacy. It's data-informed and data-based, but it's also simple to communicate, and that proves to be very effective, especially with senior political leaders. And it's also useful for accountability and reporting. So the added value that we've seen from 717, based on the initial early adopting and piloting countries, is that it complements the existing health security frameworks. It helps find system-level bottlenecks, enablers, and actions. It emphasizes the need to take prompt actions with clear metrics for all outbreaks, and that it identifies actions for continuous quality improvement. So, where we are now. As results have been published and shared, 717 has been generating a lot of interest from countries, as well as it's also being adopted and integrated into global frameworks and regional strategies. Here in Africa, WHO's Afro-Regional Office has adopted the 717 target in the Regional Strategy for Health Security and Emergencies for 2022 to 2030. And in that, it includes an indicator to have all 47 member states meeting the 717 target by 2024. All 47 by 2024. So as a result of this and other examples like it, we're seeing significant demand from countries, as well as from regions and continents and across the globe, to expand our scale and support additional implementation of 717 globally. So where is it being implemented now? 717 was originally piloted in Uganda, Nigeria, Ethiopia, Sierra Leone, Rwanda, Liberia, and select subnational areas in Brazil and the United States. Other countries that have recently adopted and begun to use 717 are Zambia, South Sudan, and Cambodia. And we're currently working with a handful of countries to adopt and begin planning and preparations for implementation, including in the Democratic Republic of the Congo, Mozambique, Pakistan, and the Kingdom of Saudi Arabia. And there's interest from many, many more. So in order to support this scale and this significant demand that we're having for this, the 717 Alliance was created. So the 717 Alliance is a country-led initiative to support countries to adopt, use, scale, and sustain 717 in their workflows. To do that, the Alliance has made some resources available. We have a technical steering group that guides our strategic direction. This region is represented by Dr. Issa Makumbi from Uganda and Dr. Elsie Ilori from Nigeria. We have a team of technical advisors that can provide direct technical support. We have launched a grant mechanism where we can offer catalytic grants in different sort of buckets of funds. There's one around country adoption to help countries to get the stakeholder buy-in and get the integration. There's one around rapid performance improvement to help resolve and implement some of those corrective actions. And then there's another pool of funds around operational research. So there are catalytic grants that are available. We've been forming institutional partnerships that help our small team to be able to scale technical support to many countries and many regions, as well as to support operational research. And we've launched communities of practice and global and regional learning networks with the idea that sometimes the best way to learn about what to do in your context is learn from the examples of others. And through this, we've also created like site visits where like the team that was planning to implement in South Sudan did a country learning visit to see how it was implemented in Uganda to get direct on-site learning experience from them. This map shows the status of 717 adoption among our countries that have formally signed a partnership MOU. So you'll see in green the countries that have that are a part of the alliance that have adopted this at national scale. In orange, the countries that have adopted this in select subnational areas. And in blue, some of the next countries that are beginning to implement. And I know some people out there are rightfully looking at this map and thinking, où sont les pays francophones? We do have DRC starting soon, and we're beginning to have discussions to implement in a couple other West African countries, but it's a priority for us to expand our implementation and examples to other Francophone countries as well. And one of the main ways that we'll do that, Dr. Virgil on the opening session mentioned the partnership with WAHO, which we're looking forward to being able to launch soon. And we anticipate that this map will be significantly more filled in the next time that you see it. So in this room, we have some just incredible leaders and experts in this field. And many of you already are or are going to be implementing 717 in your countries, and we would like to support you and we would like to work with you. So how can you join the alliance? How can we support you? How can we connect? If your country is interested in becoming a formal partner of the alliance, you can go to this. I got almost done. Yeah, it's like 2 slides. Yeah. If your country is interested in becoming a formal partner, you can reach out to us at the email address there. It's contact@717alliance.org. If you personally are interested in subscribing to get routine updates and news and notifications, as well as opportunities to participate in some of our learning webinars and training series that will be coming out over the course of the next several months, there's also a subscribe option on the website, which I'll direct you to in a second, so that you have the opportunity to subscribe to that and have personal invitations to many of these upcoming events. Speaking of those Global Learning Network webinars, next week we actually have a very exciting one where we will be talking about early action reviews and the rollout of those. So Dr. Stella gets her second shout out during this panel session, as well as Dr. Landry will be joining us from WHO to talk about the implementation and rollout of the early action reviews and how 717 is being used for that. So if you're interested in this and subscribe to the Alliance, we'll make sure that you guys have an invitation to participate in that webinar. Finally, all of this, plus additional resources to support implementation, are available on our website, which is 717alliance.org. We have materials and resources available in multiple languages. And I also brought with me, I'll take advantage of the platform that I briefly have. We have some informational sheets in English and French that we can set out maybe over on the stage or over here if you want to grab any of those, as well as some 717 Alliance business cards. And those have different URLs and QR codes. So if you are interested and you pick up some of those materials, you'll be doing 2 things. One, you'll be gaining access to all of our information as well as easy means of communication to reach out so that we can see how we might be able to support you in your efforts around 717. And you will also be making my carry-on significantly lighter for my 3 flights home, where I will be embraced into the good graces of my communications colleagues. So that's it for me. I want to say thank you, asante ni sana, and appreciate this opportunity. Thank you.
Merci beaucoup à tous.
Thank you very much to all. I think according to our program, we won't be able to answer to questions, but if you don't have a question, we do have panelists. They will answer to your questions. So we saw the presentation from Dr. Peter will talk about surveillance and how to consolidate surveillance of public health. And it says it's not just a matter of collecting and analyzing data, but how to use them and set up appropriate actions so that we can improve health of our population. The second paper, or the last one, was by Mr. Taylor, who talked about the WHO Initiative 717. And if we can summarize, the initiative is about how to detect a pandemic with 7 days after it has been signaled. So if it can be done within 24, 48 hours, that will be even better. And then we should be able to notify and come up with appropriate action to intervene. So we are going to thank all our panelists for these topics, because as you know, Africans have a lot of pandemic. We have more than 100 in Congo. We had about 5 last July. We had 3 within one town. So that is a current issue, and we will we are happy to talk about it. Thank you very much for your understanding and your participation. So we are going now to give the floor to the organization for the rest of the program. Thank you very much. We can clap. Please clap for the panelists as well.
The concurrent session before lunch. We are a little bit behind time, but we are hoping that the various moderators will regulate the time in the various concurrent sessions.
Voilà. C'est bon?
Hello, dear delegates,
would like to use the room for the next session. So we request that the networking can continue in the corridors, but allow us use this room. So we are going into concurrent oral session that is just before lunch. Concurrent oral session number 4, room 3. We are using this room. So would kindly like to use this room.
So we need to call them, all of them?
Hmm?
Yes, we can call them. Yeah, we can call them room manager. Yeah.
I want to make sure this is where the session, huh?
Yes, no, this is our session. Yes, it's this session. Oh, room 3. Room 3. Yes.
Concurrent oral session.
Yes, is that?
Yeah. Okay. Concurrent. Let me be sure.
We are not on the right page.
No, here, first wait. I prefer to see this one. Here, it's easier to read together with the concurrent oral session.
Yeah.
4.
Yeah, this one.
Thank
yeah.
you.
Just confirm the first one.
Yes.
Had it, yeah?
Yes.
Okay.
So you can call them up.
Hello. Hello. Good afternoon. Hello. Good afternoon. Can we have the presenters here in front? Eh? Let me read the name of the presenters. If I read your name, please, can you come over? We have Harriet, Matthias, Manisha. The second presenter is Diana Rose Wangari. The third presenter is Johnston. The fourth presenter will be Nasoro Juma Mwanyami from the Kenyan program. Can all the presenters come forward, please? Closing. Oh, I was reading. But I have to say the topic first.
Yes.
Okay.
I wanted to connect so that.
Okay.
I wanted to get the
Okay.
laptop ready, everything.
Okay.
Yeah. Thank you.
So do I give you time to fix?
Yes.
Are you okay now? So the sub-theme for this session will be non-communicable diseases, injuries, mental health, and vector-borne and neglected tropical diseases. And our first presenter will be Harriet Matthias Munisha. Welcome, Harriet. Sorry, I forgot to introduce the moderator. I'll allow her to introduce herself.
So, je vais parler en français.
So I'm going to speak in French because he spoke in English. Good morning, everyone. I'm here to moderate this session that is going to follow. Our first the speaker will be Harriet that is going to present to us her work on health insurance financing and patient retention in care at diabetics and hypertension clinics in Dar es Salaam. Harriet, you have 10 minutes to present your work.
Thank you very much for this opportunity. Good afternoon, everyone. My name is Harriet Matches Manisha. I'm here to present to you on health insurance financing and patient retention in care at diabetes and hypertension clinics in Pwani and Dar es Salaam regions in Tanzania. This is a story about the movement towards the universal health coverage. And as we're moving towards the universal health coverage, we're now facing a problem of non-communicable diseases, which include hypertension and diabetes, which are currently outstretching the health systems in Africa. Hypertension in Africa accounts about 10 to 20 million cases, and up to 11% of adult deaths annually. Meanwhile, diabetes contributes about 19 million cases and about 416,000 deaths in Africa. It is said that only about 5 to 30% of patients attending diabetes and hypertension clinics are currently retained in care. And poor access to healthcare as a result of inability to pay has been linked to poor retention in care. Now, while we're moving towards the universal health coverage, it is important for our health systems to meet our demands. And we have seen that health insurance is promising to improve chronic care expenditure as well as improve retention in care. In Tanzania, the prevalence for diabetes is about 14% among the adults, and the prevalence for hypertension is about 19%. We have limited data on health insurance financing and patient retention in care, and our study aimed to provide evidence for these gaps. Our objective was to determine the effect of health insurance on retention in care at 12 months for patients attending the diabetes and hypertension clinics from July 2020 to April 2022. Further, we aimed to assess the effects for, the determinants for retention in care among these patients. We used a cohort design, and we did our study across 15 health facilities, whereby our eligibility criteria was adults, patients attending diabetes and hypertension clinics who were enrolled in the Inter-Africa trial. Our sample size gave us a 95% power to detect a 50 to 60% retention difference between the insured and uninsured groups. We used the definition of retention as participants with at least 2 clinical visits that were separated by 3 months or more and not dead during the 12 months observation period. We abstracted data from the Inter-Africa electronic database, and our analysis was performed using the Starter software. Proportions were compared using the chi-square tests, and incident rates for retention were obtained using the Poisson regression analysis. These were our results. We followed 1,716 patients for 1,612.3 person years, and each participant was followed for at least 12 months. We observed very high retention rates, which was 83.8 per 100 person years. These were the social, demographic, and clinic characteristics. As you can see, the female participants contributed about 66.1% of all insured participants. The age group that was 45 to 64, which is considered the middle-aged adults, contributed about 58% of all insured participants. And also participants that had hypertension alone contributed about 55.3% of all insured participants. Coming to our main questions, from our study, health insurance had no effect on retention to care. On the other hand, participants that were aged 65 and above, participants that had 45 to 64 years, that were 1.16 and 1.1 times more likely to be retained in care compared to participants that were young adults. This was the age between 20 to 44. Participants that had hypertension alone and participants that had diabetes alone were 1.2 and 1.19 times more likely to be retained in care compared to those that were diagnosed with hypertension and DM. Participants that had a comorbidity of hypertension or DM with HIV or diabetes with HIV were 1.2 times more likely to be retained in care compared to participants that had a single condition that was either hypertension or DM. And participants that were attending hospitals and healthcare were 1.12 and 1.13 times more likely to be retained in care compared to the ones that were attending dispensaries. Now, from our study, health insurance had no significant effect on retention to care for our study participants. There was no study that was done on HIV that's relating NCDs and retention in care that we could relate to this finding. However, there was a study that was done with HIV in the US, which is also a chronic condition, and in US, the services are not free as in Africa. Most of them have to pay, and a few are in aid programs. So in this study, health insurance had significant effect on retention to care. The retention rates for our study were very high, as we have seen, and this might have rendered it difficult for us to detect the differences that might have existed. Otherwise, other studies in Africa have reported low retention rates, which include, there's a study done in Malawi and one in Kenya, and this is contrary to our findings. High retention rates in our study may have been due to the influences, probably due to the influences of COVID-19 that was happening during the study period, which might have encouraged participants to care seek or have care-seeking behavior. Otherwise, maybe influences from the large trial, the Inter-Africa, encouraged participants to come to attend hospital, to attend care because they were aware that they were being followed. Otherwise, there was a similar study in Malawi relating, showing that age was related to retention in care, but we couldn't find studies that could relate medical diagnosis, comorbidity status, and health facility level to retention in care. These are some of our strengths. This was one of the very first studies investigating health insurance financing and patient retention in care in Africa. We had a smooth access to large sample size with good quality data provided by the Inter-Africa trial. The settings from our study was from 2 coastal regions. Hence, this study may not be suitable for generalization. However, we considered all levels of primary health care in our country, which includes the dispensaries to the hospitals. High retention rates observed may also have rendered it difficult for us to detect the differences that exist between insured and the uninsured participants. Now, these are conclusions. Obviously, no effect of health insurance to retention in care. However, age, medical diagnosis, mobility, and level of health facility were related to retention in care. Now, we do recommend that we need further research, which is more inclusive, research that explores the role of health insurance in chronic care management, including the quality, to describe the level of care that is given to these participants,
And we also need to find solutions to health financing in chronic care, as we've seen that probably health insurance might not be our solution after all. Otherwise, we need policy reviews and changes among policymakers to include chronic care management, including the financing options that are friendly and that include our current needs. I would like to thank everyone for listening and attending. You're welcome.
Thanks very much, Harriet, who took 9 minutes. Our next speaker is Diana, who's going to present the associated factors on complications for diabetic cases in the district of Kitui.
Good afternoon, everyone. I'm here to present on a study we conducted on factors associated with diabetes mellitus complications in Kitui County, June to September 2018. So diabetes mellitus is a common metabolic disorder that results in hyperglycemia, which could be due to reduced insulin secretion or insulin resistance that leads to a state of hyperglycemia. Chronic hyperglycemia is associated with micro and macrovascular complications such as end-stage renal disease, diabetes foot, blindness, and these have a tremendous burden on families and the healthcare system. So globally, we have 537 million people living with diabetes. That is as of 2021. Africa has 24 million people living with diabetes. And in Kenya, according to a stepwise survey done in 2015, we have 1.9% patients with diabetes, and it's projected to increase to 3.5%. In Kitui, where we conducted the study, we have limited data on the prevalence. So we conducted this study to describe the socio-demographic and clinical characteristics of the diabetic patients attending the Kitui County Referral Hospital Diabetes Clinic, and also to identify factors associated with the diabetes complications among these patients. We conducted this study in Kitui County Referral, which is a hospital in Kitui County, found in the lower eastern part of Kenya. It's one of the arid, semi-arid counties, and the hospital has a catchment population of 1.2 million people. It has a diabetes clinic that runs daily. That was an initiative by the Ministry of Health, Division of Non-Communicable Diseases, and it started its operations in June 2018. We looked at records from June through September 2018 in the daily and permanent Ministry of Health diabetes registers. We calculated proportions and frequencies for categorical variables and measures of central tendency and dispersion for continuous variables. We also looked at outcome variable, which was diabetes complications, and exposure variables, including age, sex, residence, duration of illness, comorbidities such as hypertension, and we looked at the prevalence odds ratio. We used 95% confidence interval, and values that had a p-value of less than 0.05 were considered to be statistically significant. We sought permission to conduct this study. So as for results, we had a total of 305 records, which we abstracted from the registers. And out of those, we had 222, that is 72.7% being females. The mean age was 55 years with a standard deviation of plus or minus 15. And the highest proportion of cases, as you can see, was 45 to 64 years. On the residents, we see that 54.4% of the patients came from Kitui Central Sub-County, which is where the hospital is. We looked at the National Hospital Insurance Fund, which is a Kenyan government state corporation with a mandate to provide accessible, affordable, sustainable, and quality health insurance to all Kenyans. And we saw that 61.3% of the patients did not have this insurance. On the clinical characteristics, 94.1% of the patients had type 2 diabetes mellitus. We used the Kenya National Guidelines on Diabetes Management to classify patients as having controlled or uncontrolled sugars. So for controlled, we looked at patients with a random blood sugar of less than 11.1, that is for the elderly. And for those who are who are less than 65 years, a blood sugar of less than 10. So we can see that 59.7% of the patients had uncontrolled sugars. For the blood pressure, those who had a blood pressure of more than 140 millimeters of mercury were 50.1, and those who had the duration of illness for less than 5 years were 59%. We looked at waist circumference, which is a surrogate for adipose tissue, which is performed on the horizontal plane above the iliac crest. So it's a measure of central obesity and is an indicator of metabolic syndrome. And these are the cutoffs. So in total, we had about 72% of the patients having an abnormal waist circumference. And out of those, 59% were females. Among the type 2 diabetes cases, which were in total 287, more than half were on oral medications. And on those of oral medications, the majority had uncontrolled sugars at 47.4%. We looked at the complications that the patients presented with. So these are some of them. We had the macrovascular and microvascular complications. Among the macrovascular, we had diabetes foot, heart failure, stroke, ischemic heart disease. And on the microvascular, we had nephropathy, neuropathy, retinopathy, and erectile dysfunction. And 9 patients, that the largest percentage was 3%, presenting with diabetes foot. We looked at the factors that were associated with these complications. So those who were 65 years and above, males, those who had underlying hypertension, and those who had the disease for more than 10 years had an increased odds of developing complications. So on discussion, we see that Kitui Central Sub-County had the highest proportions of patients at the clinic, and this could be attributed to the proximity of the clinic to the residents of that sub-county. We see that about 3/4 of the patients were female, and this could be attributed to the fact that they are the at-risk group. They are more likely to have central obesity, which is a risk factor for diabetes. More than half of the patients did not have a medical cover with the NHIF, which is the National Hospital Insurance Fund. And this could be attributed to the fact that majority of the patients were unemployed or retired, and leading to out-of-pocket payments, which could explain the poor outcomes. Majority of the patients had type 2 diabetes, and we can see that Kitui County, especially the Kitui Central Sub-County, is a rapidly growing town. And we have risk factors such as urbanization, sedentary lifestyle, and inadequate diets, which are a major risk factor for type 2 diabetes. More than half of the patients had a high-risk waist circumference, poor sugar control, and poor blood pressure control. And this could be linked to low levels of education on self-care, weight management, and diet. Most of the type 2 diabetes cases were on oral medication with poor sugar control. This could be attributed to clinical inertia, which is a reluctance of clinicians to initiate insulin for these patients. About 1/10 of the patients presented with a pre-existing micro or a macrovascular complication. And we saw that males are more likely, because males are more likely to use tobacco and alcohol, thereby increasing their risk. Those above 65 years, we have aging effects that combine with the diabetes, thus accelerating the complications. Underlying hypertension, those who are hypertensive also increase the cardiovascular disease risk. And having diabetes for more than 10 years, because this group is likely to be lost to follow-up and not adhere to the medication. So in conclusion, we've seen that majority of the patients did not have a national hospital insurance fund. Type 2 diabetes mellitus was the most common. And we saw that majority of the patients had poor sugar control, likely due to clinical inertia and lifestyle choices. Majority of cases were females due to central obesity. And patients at risk of these complications include the elderly, hypertensive, the male patients, and those with a long duration of illness. So we recommend that there is need to focus on the at-risk groups. So they need close monitoring of elderly and male patients. We need to screen for obesity and offer behavioral modification counseling to promote weight loss, and also self-help groups among women for education on prevention. So we disseminated this information on the first picture to the county management teams and also the hospital staff. And also, as one of the recommendations, we began to educate patients on every visit. So we counseled on group, we normally counsel on weight and also diet and physical activity for every visit, and we do group, we do group counseling. Some acknowledgements, references. Thank you very much for your time.
Merci beaucoup.
Thanks very much. The third presenter is going to present the results of their work for patients who are enrolled into a program of distribution of medicine in KwaZulu-Natal.
Thank you. Yes, that's mine. Thank you. Oopsie, sorry. Okay. Thank you very much. My name's Lee Johnston. Thank you for introducing the topic for me. Let's maybe jump straight in. Type 2 diabetes is a growing public health concern in South Africa. As we can see in this picture, while communicable diseases are on the decline, mortality rates for non-communicable diseases continue to increase. In Stats SA report in 2018, diabetes was the second-ranked leading cause of death in South Africa, and there are currently 4.2 million people living with diabetes in South Africa. Because diabetes is a chronic condition, guidelines exist to help manage the condition. Here we're presenting guidelines from the Society for Endocrinology, Metabolism and Diabetes in South Africa. They recommend an optimal target of HbA1c that's less than or equal to 7%. And they recommend a testing frequency of 6 months if they are optimally controlled, and 3 months if they are suboptimally controlled. And good control is so essential because it will help reduce the risk of diabetes-related complications, as we can see listed in the figure below. Because of the burden of diabetes in South Africa, the National Department of Health has introduced targets for 2030, and the one we will be honing in on is the proportion that are controlled who are receiving intervention. The target is for 50% by 2030. Unfortunately, to date, we don't have any data on what those proportions are. So we had the opportunity to now link data for people who are enrolled in a medicine dispensing program for their diabetes medication to their HbA1c laboratory results to see how they were tracking over time. So to maybe just introduce you and contextualize the programs a little bit more, the CCMDD is the Central Chronic Medication Distribution and Dispensing Program in South Africa. patients would essentially, it's a program that is designed to improve medication access for people with stable diabetes. It aims to make this a more user-friendly service so people have reduced transport costs and reduced waits and queues at clinics. Essentially, the patient will see the health care provider at the facility level. If they're suspected for diabetes or if they need to monitor their levels, they will send the results to the National Health Laboratory Service, or the NHLS. And if they had 2 consecutive results with a fasting plasma glucose of less than 7 millimoles per liter, and if they hadn't changed their medication over the last 12 months, they'd be eligible for enrollment into the distribution program. And that affords patients the opportunity to then collect their medication on a 2-monthly basis from community-based pickup points instead of going to clinics. Unfortunately, though, after that point, there's no more follow-up for their clinical measures within the CCMDD. And because the NHLS houses laboratory results for 80% of the public health population for the public health sector, we had the opportunity to link the 2 data sets to try and monitor this control. So our aim was to determine the proportion of type 2 diabetes mellitus CCMDD enrolled patients who had optimal glycemic control at enrollment, as well as the rate and predictors for becoming suboptimally controlled. And here we can see an example of the CCMD pickup points at clinic level. Our study setting was within eThekwini in KwaZulu-Natal, as you can see indicated in the picture here. We chose this as KwaZulu-Natal has the second highest incidence of diabetes in South Africa, and eThekwini represents 1/3 of all the type 2 diabetes-related clinical visits occurring in KZN. Our study design was a retrospective longitudinal cohort study. We enrolled the population was CCMDD enrolled patients in eThekwini in South Africa from between 2018 to 2021. And our exclusion criteria were patients suboptimally controlled at their initial HbA1c, done closest to enrollment, and who had no repeat measures available thereafter. Our outcome definition for glycemic control, it was optimal if there was an HbA1c that was less than or equal to 7%, and suboptimal if it was greater than 7.1%. And for our survival analysis, we use the definition of time to failure as the first date of the change of status to suboptimal control, or the end of the study period for those who needed to be right-centered or who remained optimally controlled. For data management, we used data, and we merged the CCMD line list with the NHLS laboratory data based on ID number. It was then cleaned, and we created the predictive variables that you can see in the gray block. I'll just talk a little bit more to mono and dual therapy. Patients with diabetes would initially be managed with lifestyle changes, and if their blood sugars wasn't controlled, they'd then be escalated to monotherapy, and then to dual therapy and insulin therapy progressively. And we also looked at adherence to the guidelines for testing frequency, and we used the SEMDSA guideline that we referred to earlier. For our descriptive analysis, we looked at proportions achieving glycemic control. We looked at their demographic and clinical characteristics and overall hazard rates, and then also the median time between tests. Our survival analysis then, we used Kaplan-Meier curves for the analysis. Then we looked at the log rank test to compare the survival curves between the different variable strata. And then we conducted a multivariate extended Cox model. In summary, of the 40,000 odd who are enrolled in the CCMDD and receiving oral medication for diabetes, 81% had no result available in the NHLS over the study period. Of those that did have, who did have a test available, there were about 8,000. Only 27% were actually optimally controlled at the initial test, closest to enrollment. And of those who were optimally controlled, only 33% could be taken forward into the survival analysis because they had a repeat test available. So to describe the 695 who you could then take forward into the analysis, the majority were female, aged between 40 to 79 years of age, attended primary healthcare facilities, were receiving monotherapy, and had a comorbidity of hypertension. 54% had a type 2 diabetes-related complication, and here we could refer to nephrology or nephropathy. 33% changed status from optimal to suboptimal control over the study period, which was a hazard rate of 137 per 1,000 person years. And the median time between tests for those optimally controlled was 12 months, which is within guidelines just. And for those suboptimally controlled, it was 13 months, which is well above the recommended guideline of 3 to 6 monthly testing. Here we are looking at the Kaplan-Meier survival curves for the probability of remaining optimally controlled over the study period. The x-axis here represents the study year, and the y is the survival probability. Factors that were significant enough with a log rank test with a p-value of less than 0.25, we then took forward into our final Cox model, and those were gender, therapy, facility type, and adherence to the guidelines. The adjusted hazard ratio for those who used dual therapy was 50% higher than the hazard for those using monotherapy. The adjusted hazard ratio for those treated in accordance with the testing guidelines was 54% lower than those who weren't. And the combined effect of facility was a 27 decreased hazard for those attending hospitals versus primary healthcare facilities. Similar findings have been found in Gauteng province when they also looked at NHLS data, and they also found that 74% of patients who had an initial HbA1c had no follow-up test in their 4-year study period, and the testing guidelines also didn't comply with the SMDSA guidelines. Also, a study conducted in Tshwane in Gauteng province in South Africa in 2019, that was a clinical file audit, also found that only 29% of the CCMD enrolled patients had optimal control. This might be explained by us using HbA1c to define control, whereas CCMDD uses 2 consecutive fasting plasma glucose levels. Factors that were associated with being suboptimally controlled, our study agreed with studies from Australia and the UK that also found that adherence to guidelines was protective for developing it. But despite policy being placed, it's not being implemented for this cohort. And as in a study in Lebanon, they also found that dual therapy was a higher hazard for developing suboptimal control. And this might be because these patients reflect a group with higher rates of past failures or vulnerabilities to developing suboptimal control. Initially, the hazard at hospital level was higher, and this might be because those patients who are more complicated in nature are generally up-referred to hospital facilities, but this effect did seem to decrease over time, and this might be because hospitals in South Africa have more multidisciplinary programs available, like diabetes clinics versus PHCs. Similar results were also found in the study we spoke about in Gauteng with the NHLS laboratory data. And as they suggested, we also suggest this might be due to lack of resources, equipment and infrastructure, and also an unwillingness for healthcare workers to integrate diabetes care into their routine services at primary healthcare level. The strengths of the study was that it was a good representation of CCMD enrolled patients in eThekwini. It reflected patients spread across 13 hospitals and 107 primary healthcare facilities in eThekwini. And this was also the first time that these patients were monitored in terms of their control, despite this being a very large public health program in South Africa. The limitations of the study was that we weren't able to include insulin users, which are a very important part of the population for people living with type 2 diabetes. And also there were many factors that we weren't able to include just because they weren't available in either data set. In terms of public health action, to date, both the CCMDD and the NCD Directorate in the National Department of Health have started to conduct facility audits in eThekwini to try and determine the low rate of testing, despite the guidelines for care being in place. And furthermore, we also recommend reassessing enrollment criteria into the CCMDD from the status quo of fasting plasma glucose to rather using HbA1c. And we also think there needs to be an exit criteria for those who become suboptimally controlled, and this would require a mechanism for CCD to link data to clinical data so that they can flag those who need to leave the program for more frequent follow-up at clinic level. We also recommend using innovative technology and community-based interventions to try and increase the HbA1c testing for this cohort. And we would also suggest training healthcare providers on the guidelines for care for diabetes. So in conclusion, while the CCMDD is invaluable in improving access to medication for stable people living with diabetes, this study can alert policymakers that the majority of patients weren't optimally controlled and that other barriers to care still obviously exist, and these might be related to insufficient testing and other vulnerabilities. And addressing these shortfalls might help us address and reach our targets of 50% of those receiving treatment actually achieving glycemic control by 2030, and of course to help strengthen our health systems. These are references. Thank you. Asante sana.
dernier à faire sa présentation.
The very last person to make a presentation will be Nasoro, who is going to present to us her work, that is, who takes methadone in Mombasa in Kenya. Who takes methadone in Mombasa?
Thank you. So I'm Nasoro. I can just read this quote that says, "The epidemic of opioid addiction and its consequences touches every community, every demographic, and every single one of us in some way." So in that regard, I want to present our work on who is taking methadone in Mombasa, Kenya, characterization of opioid users entering methadone clinics. I'm Nasoro Juma Manyalu, an FLTP student from Kenya. So medically assisted therapy, also called methadone maintenance assisted therapy, is the use of approved medication, including methadone, buprenorphine, and naloxone, in combination with counseling to treat opioid use disorder. The WHO and other collaborators endorsed MAT as the most effective harm reduction strategy to treat opioid use disorder. In Kenya, the presence of heroin has been reported since 1980s, and in that regard, Mombasa County, being in a strategic position for Mombasa County being in a strategic position, has been identified to have high number of people who inject drugs, which range from 18,000 to 30,000, of which 18% are HIV positive. So in that regard, Kenya adopted MAT program in 2014 with an aim of preventing further spread of HIV and stop and mitigate the effects of injecting. In this country, or in Kenya, the drug of choice to treat opioid use disorder was methadone. By the year 2020, 9 MAT sites were launched across the country, in which the majority of these 3 sites were launched in Mombasa County, since it was identified as the county with high burden of opioid use disorder. By the year 2022, 66% of clients taking methadone treatment in Mombasa were active for MAT program. So, however, despite having high retention rate, little is known about the characteristics of these clients assessing MAT services. Therefore, there is a need to characterize patients who are entering MAT program so that we can use this data to inform progress and planning for harm reduction programs in the country. So the main the objectives of this study were to describe the social demographic characteristics, determine the prevalence of infectious diseases, and also assess the treatment outcomes among the MAT entrants in Mombasa MAT clinics, that is between the period 2015 to 2022. So this study was conducted in Mombasa County among the 3 MAT sites, and during this study, we included all the records for opioid users enrolled in the program, and we used a data abstraction tool to collect this data. So this was a retrospective records review, and the key variables that we extracted included the patient demographics, treatment outcomes, and clinical findings. On analysis, or during the analysis, we just did descriptive analysis for this study, whereby for continuous data, we calculated means and median, while for categorical data, we calculated proportions and frequencies. So the results of this study is that we found that from the year 2015 to 2022, the MAT programs in Mombasa County had enrolled 1,767 clients, of which over that period, from 2015 to 2022, the number of females, that is the line in blue, there have been fewer throughout the period. Interestingly, there was a variation in enrollment throughout the year, but of key interest is that during the period, during the term of COVID-19, there were spikes in enrollment. So the reasons for these spikes can be hypothesized that during COVID-19, there was scarcity of heroin. Therefore, the opioid users opted to join MAT programs so that they can treat their opioid, so that they can treat the opioid cravings. So on social demographic characteristics for these enrolled clients is that the mean age was 37 years with an SD of 12.7. Overall, the majority of these clients were male, whereby it contributed at 8.1%, and they were older, since 60.2% of these clients were above, of the male clients were above 35 years. Contrary to the females, whereby 62% of them, they were below 34 years old. So this shows that females were younger compared to their male counterparts. On the level of education, at least when you look at it, the primary level education was at 56%. And of interest is that among these clients, we also identified clients that have post-secondary education, which was at 5.9%. On marital status, it has been documented in several studies, or as it is being expected, the majority of the clients were not in a relationship, since this could be attributed to that during opioid use. Clients opt to get to be addicted to opioid and live out, and they're not engaged in any relationship. Furthermore, or similarly to that, we also saw that unemployed clients were contributed the highest at 69.4%, similarly to several studies that have been conducted among the opioid users across the globe. On prevalence of infectious diseases among the MAT entrants, HCV or hepatitis C was at 7.0%, while HIV was the highest at 10.9%. When we compare these findings with the general population in Mombasa County, we see that HCV had 4-fold higher prevalence among the opioid users compared to the general population. Hepatitis C had a 3-fold higher prevalence. And for HIV, the prevalence of HIV among opioid users, it was 2 times higher compared to the general population, which is at 4.8%. So when we segregated the HIV prevalence per gender and sites where the clients were enrolled, we find that female had 4 times more prevalence of HIV compared to their male counterpart at 32.9%. And when we look at clients who were enrolled in prison, 10% were positive for HIV. And the key thing to note is that there were 0 females enrolled from prisoners. And as I've said it earlier, opioid use affects every demographic. But here, we see that in prison there were 0% or 0 clients enrolled in female prisons. So when we look at modes of drug use among these clients, we see that what we record or what we found is that it is contrary to the objective of the MAT program, whereby the total number of clients enrolled in MAT sites in Mombasa, only a third of them were injectors, and the majority were non-injectors. And as it has been documented in several studies, injectors usually had higher HIV prevalence, and in this study we reported the HIV prevalence among injectors at 16.1%. So this was 2 times higher prevalence when you compare to the non-injectors. On treatment outcomes among the MAT entrants, we see that only 3% have been weaned off, and for the clients who are active on MAT, they were at 61.6%. This is within the range that has been documented globally. This is the number of active clients globally is between 60 to 65%. On HIV positive clients, there was higher retention rate or adherence rate among those who are taking ART and Methadone at 98.4%. So the conclusion is that we saw that there was a spike on enrollment we found that there was a spike on enrollment during COVID-19 pandemic. There was higher HIV, hepatitis B, hepatitis C prevalence among the drug users in the country. there were more non-injectors assessing MAT services. There was high HIV prevalence among injectors and females, and females prisoners were not enrolled to MAT program. Overall, MAT retention was poor. However, we recorded a high adherence among clients who were on RT. So we recommend that we need to enroll more women with opioid use disorder, and we recommend to use their peers. And also we need to strengthen screening and treatment for hepatitis B and C, implement comprehensive HIV prevention package for opioid use disorder, including which can incorporate addressing additional vulnerability for women, scaling up harm reduction strategies, including the needle syringe program, and also we need to strengthen retention strategy for all MAT clients through psychosocial support. So the public health action that we shared feedback with the staff at Kisauni MAT Clinic, and that they updated their patient files. So I would like to acknowledge the followings. Those are my references. Asanteni sana.
Merci à nos 4 présents.
Thank you very much for the 4 speakers. We had some time constraint. My name is Dr. Laurent Mariam, technical advisor within our regional center on surveillance for the West African Organization of Health. So we have with us 2 assessors. That is Joseph and Dido, and the manager, Dr. Ado. So we are going to give the floor to give you the floor after this for presentation. I hope that you noted your questions. We are going to give the floor to 4 people, and if we still have time, we will have a second round of questions. So we are going to raise your hand, introduce yourself, and define to who your question is addressed. Thank you.
Well, good job, presenters. That's excellent presentation from everyone. I particularly was paying attention. I think the first presenter from Kenya talked about the health insurance and noticed that because of preponderance of high retention, it didn't look like health insurance made a difference. So I was wondering, in the circumstance where we have free health care, or people get access to health care as you compare to the US where they had HIV, where the health service is paid for through insurance. What were we expecting when there's free health care? Should that not be driving the high retention? In other words, since cost or health care cost was not a limitation, wouldn't that be obvious that insurance might not be a significant contributor to retention? Maybe I didn't quite get the clarification. Maybe you can clarify. Why were we surprised that in a setting where healthcare cost is funded, or it does not, insurance shouldn't play a role in determining the level of retention? If you can clarify that.
Thank you very much. The presenter has made a fantastic job. I have 2 questions. One is for the presenter from Tanzania. You reported a national prevalence rate of 19%. This is shockingly high compared to the rates in the rest of East Africa, where diabetes prevalence is about 4.5%. The rest of Africa, it's also around 4 to 5%. Do you know what possibly explains this high prevalence of diabetes in Tanzania? And then, do you plan to look at the differences in terms of quality of care, glycemic control in those with insurance versus those who are not insured? And then to the presenter in Kenya, What explains these excellent treatment outcomes? If you ask me, the rates of complications were quite low compared, for example, to the presenter from South Africa. I found a prevalence of complications of about 10% to be quite low compared to what is published in literature. Do you know what the median time on treatment was like and levels of glycemic control? Thank you.
Thank you. My name is Peter, and I'm a medical epidemiologist by training. I have 3 questions. One to the first presenter. Would you mind telling us about the health financing insurance in Tanzania? I think I missed that. And then, coupled with that, would you also tell us if there were any differences that you saw if you segregated by the type of diabetes? I think you just lumped up diabetes, but do you think if someone had type 1, they were more likely to be retained in care than folks who had type 2 diabetes? And then for presenter 2, what's the prevalence of diabetes in males versus women in Tanzania? I don't know if it's Tanzania or Kenya, but because there were 3/4 of women who were seeking health care compared to men. Just 1/4 of the men were seeking health care. And do you think health-seeking behavior should be a recommendation for men if they are more at risk? I know you said it was women because they have one of the risk factors of central obesity, but do you think, compared to the population, as part of your recommendation, you should include health-seeking behavior in men? And then for presenter 3 from South Africa, could you tell us the lost follow-up rate in your study? And then I know you mentioned that as part of the limitations you had in your study was that key predictors were not included in the database. Do you think in your recommendations you'd indicate that for the database to capture those key predictors? Because I think you're missing out a large section of predictors that could actually influence care. Thank you.
Good afternoon. Thank you. I'm Ali Hussein from Tanzania. I have a question for the presenter from South Africa. I wanted to know the main exposure variable for your analysis, as I saw many Kaplan-Meier survival curves, and then you performed the extended Cox model. So maybe you tell us more about the assumptions, if they were met for doing that analysis, or vis-a-vis the Cox proportional hazard model. Thank you.
Sorry. Donc, la présentation sur le financement.
So the issue of funding on health coverage, the issue of diabetes, 2 questions. What are the factor on the control for glycemia? And then for the third question, I give you the floor so that you can start giving answers. Thank you.
Those questions. So the first question was on why there is a low prevalence of complications as compared to other studies that have been conducted. So one, I'd attribute that to the fact that where we conducted this study is in an arid, semi-arid county where there is high levels of poverty. And for us to diagnose these complications, we need some costly tests. For example, we need ECG echoes, which are used to diagnose heart failure or ischemic heart disease. We need tests such as CT angiogram, which are needed to diagnose issues to do with diabetes food complications. We need also tests such as lipid profile. So in this setting of ours, which was an outpatient setup, most of the patients coming in could not afford those tests. So we were more likely to diagnose these complications in an inpatient setting, where patients now have come with already end-stage renal disease or stroke that now they require an admission and need those tests urgently. But for patients coming in and asking them, okay, you need to do this series of tests, most of them could not afford them. So the complications that we were able to diagnose were just about 10%. And then the other question was to do with why we had more females compared to males seeking care. We see that, first of all, females have more risk factors to diabetes. And the most common is central obesity compared to males. And then males, of course, have a poor health-seeking behavior, as we've seen in they're the ones that are now commonly coming in when they have complications. So the odds of developing complications was more in males because they come in late. However, females have more risk factors and, of course, have a health-seeking behavior that is better than in males. Therefore, they come to the clinic more often. Yeah, thank you.
Thank you. For the first question regarding the loss to follow-up rates, so for this study, we were matching the two data sets. And as a result, like I said, we could only take very few into the actual survival analysis. So we lost 33% who had no follow-up at all, who had a baseline available, to answer your question. And then we just looked at survival time. So at the first failure, that was what was then counted for the survival analysis. And in terms of looking at other key predictors, unfortunately, there's very limited data in South Africa for diabetes, which is a huge problem. But the CCMDD is a program that dispenses medicine, and the data that contains is the type of medication that was prescribed and the dates it was prescribed on and when they were initially enrolled. So it can act as a proxy for adherence, but that's all the data that's in there. And the NHLS, of course, is just the actual HbA1c results and the dates that the tests occurred on, and if the result was optimal or suboptimal, the actual test value. So yes, while we would love to have much richer data, person-level data, to take forward and to really understand the problem of diabetes in South Africa, it's just not available at present, to answer your question. We have recommended to the CCMDD, it's a short presentation time, unfortunately, but we have made recommendations to them that they make use of community healthcare workers and leverage the good work they've done with HIV, with home visits, to try and collect more data elements, such as obesity and weight, length of diabetes, and other factors that we know are so incredibly important, and risk factor information, of course. And then this was a survival analysis, so our outcome variable was time to failure or time to first optimal control. And as a survival analysis, we then do a bivariate analysis where you put each variable against that and assess if it was significant or not. And that's where we use the log rank test, and we use the cutoff of less than 0.25, as I mentioned. And those are the variables that we took forward into the extended Cox model. And we use an extended Cox model because facility type violated the assumption of proportional hazards, and that's why I was reporting that initially those who were attending hospitals had a greater risk, but over time that risk decreased as we took, the interaction of that with the log of time into account. And I'm so sorry, I didn't quite catch the last question. My headphones were causing me trouble. I'm not sure if it was directed from you. Did you ask? No? Okay. Thank you. Thank you for all your questions, and I hope that addresses them. Thank you very much.
Thank you once again. I would like to thank everyone who participated in asking the questions. Those were very insightful questions, and they made me think a bit in trying to respond to them. So from the first member or participant that asked, I think you were asking on the comparison that I made with the HIV program in the USA. I think that's correct. And why, yes. So I think that's what you were asking. Why did I compare my findings with the HIV program? And what I was trying to explain is that in the USA, the HIV program is not free, unlike the settings in Africa. So we expect that we have almost similarities as in with the programs, the non-communicable programs in Tanzania where people are expected to pay. So this is relevant because the HIV is a chronic or lifelong care condition, and these people in the US are also required to pay. There's only a few people that are under assistance, and so this was relevant into this context. And in comparison with this study, there was a significant relationship between the patients that were using health insurance compared to, with retention in care. I hope I've answered that correctly. And the other member asked about the prevalence of diabetes. Actually, the prevalence of diabetes, as I reported, was 14%, and for hypertension, the 19%. Yes, this is very high, and this is from the most recent data from a STEP survey that was conducted recently. And this might, I don't have all the answers, but this is mostly attributed to the rapid lifestyle changes that are occurring in our country. And also we are seeing that there's more access to food, and more people are not engaged in a lot of physical activity. So I think those are one of the factors that are contributing to the rise in the diabetes prevalence. But we are seeing this rise in all countries. We're seeing this shift and burden growing all over Africa. The other question was about whether we assessed the quality of management in care, and whether we tried to describe whether there's a difference between the level of quality between the people that are on health insurance and those that are not using health insurance. Well, our study was very broad, and we explored more on health insurance, we explored the coverage and other factors for health insurance, which were not represented in this today's representation. But we did not include, and there's a lot of data that was collected, but we did not include that. We just selected a few to present on this presentation. We also saw the biomedical indicators were not presented today, but the data was collected and analyzed. Another question was, how is the health financing issue in Tanzania? I'll try to answer this as much as I understood the question. So in Tanzania, more than 50% of health financing is now out-of-pocket expenditure. So people they pay cash upfront, but we have less than 20% of people in the general population that use health insurance, and among these, we have the National Health Insurance, which is a public scheme, which we have less than 10% are enrolled in this scheme, and we also have private schemes where it is estimated about less than 7% is enrolled into this scheme, and also we have the community health insurance, we have less than 7%, and the private health insurance, we have about 1 to 2% enrolled into these schemes. You asked whether we could analyze or segregate between diabetes type 1 and type 2, and for our study, we were concentrated on diabetes type 2. I hope I answered all questions. Thank you very much.
Merci à tous pour l'intérêt.
Thanks very much for the interest that you have shown to these presentations. We are at the end, and we are going to give a round of applause applause to the participants now that they have shared their results. And we wish you that you enjoy a good meal. Enjoy your meals.
So we will break for lunch. Point. It's going, I can assure you it's going to be a very fast process because many people have had their lunch. So we will use 30 minutes. We'll be back by 2:30 so that we can start the plenary session. We have to be, we have to, be on time for the afternoon session because this room is in use for other things at 5. So 30 minutes. 2:30, we are starting the plenary session. We have coupons. If you have not received a coupon, please don't go minus it. Oh, okay. Let me. Just give me a second. I've run out of it. Where are these people? Just hold on. If let me organize coupons at both entrances, exits. Just head to the exit. Hi, Rocky.
The chords are already made for you.
We can drag one of these chord progressions in.
How to get the most of Grammarly free.
It's Kayla on behalf of Grammarly to tell you all about the free version of the best communication assistant in the world. Millions have chosen to go beyond their default.
check, 1, 2, check, 1, 2, 1, 2, check, 2.
A perfect family is not always what it seems.
Hapa hakuna mtu anaweza kunificha kitu.
When a father's past is revealed after his death, living his empire in
such a rush, my baby, slow down, come find your love. I'm hoping you see me, come serve it up. Love it when you stir it up. That body belong on TV. Oh, this feeling I can't hide. You're feeling up my mind, and I just don't know why. I just don't know why.
Testing. Okay. Okay, ladies and gentlemen, we'll begin in 2 minutes. Nous commençons et 2 minutes.
I'm going to start in 2 minutes.
Okay, ladies and gentlemen, it's time to begin session 3 on vector-borne and neglected tropical diseases. Unfortunately, so we have 2 speakers. So to begin, I would like to welcome Professor Fred Newton-Binker to the stage, and also Professor Placide Mbala to the stage. Thank you. Okay, just to remind you, we will have both speakers speaking for approximately 15 minutes, 5 minutes of questions. In the essence of time, both speakers would speak after each other, and then at the end, we'll have a Q&A session. Okay, to begin, I would like to introduce our first speaker, Professor Fred Newton-Binker. We'll be presenting on dealing with malaria challenges in Africa prospects for elimination. Professor Fred Binker is a professor of clinical epidemiology at the School of Public Health, University of Health and Allied Sciences. Previously, he was the coordinator of the WHO Emergency Response to Resistance in the Greater Mekong sub-region of Asia. He was the Foundation Vice Chancellor of the University of Health and Allied Sciences, established by the government of Ghana in March of 2012. He also served as the Dean of the School of Public Health at the University of Ghana. He worked with the Ministry of Health in Ghana for over 20 years, and he's also established an in-depth network made of 54 field sites in 24 developing countries in Asia and Africa. Professor Binker has served on more than a dozen WHO expert committees and panels as chair of the Gavi Development Review Committee for 4 years and a member of the Malaria Advisory Committee. Professor Binker is a trustee of several international non-governmental organizations working on health. He's also a member of the board of the International Vaccine Institute in Seoul, South Korea, and a member of the past council of the Ghana Health Services, Ministry of Health, Ghana. He is one of the founding members of AFENET. He was also the first recipient of the Rudolph Award in 2001 from the RD Tropical Medicine for his work on malaria, an honorary fellowship of the American Society of Medicine and Hygiene in 2015. Ladies and gentlemen, please welcome Professor Fred Newton-Binker presenting Dealing with Malaria Challenges in Africa, Prospects for Elimination. Thank you.
This goes front and back. Thank you very much for those very kind words. Sometimes you're not sure whether you're the person he's talking about. Thank you very much. And it's a real pleasure to be here today to talk on this subject on malaria. I'm
really, how would I say it? I was really blown up when this started yesterday. And I saw the number of people who came here, over 1,000 young people who are here to exchange ideas and to move this whole business forward. And when I look back, just a few years back, in fact, we will not fill one of the side rooms if we were to call a meeting of the AFENET at the time. So thank you very much, the team, Executive Director, Dr. Samantara, the current chairman of the board, and the board members for the great work you are doing. Today, I'm going to go a little bit fast because 15 minutes is a very short time to get these things done. So I have cut off most of what I wanted to share with you, and I'm going to focus mainly on the challenges about dealing with malaria in Africa. Even that, I only touch one or two bits, and I hope that it will come across and we can have a chat at the end of the day. So the good news is that malaria, we are eliminating malaria in many countries in the world. There was a register that was started many years ago and they stopped. By 2007, nobody was looking at the register any longer. But then it started again from 2007, and as at 2019, about 31 or so countries had been certified free of malaria. Then beginning started, and we have an what's happening? Sorry, it's a small break about the slides not being on the screen. I didn't notice that. So as I said, by 2019, we had a fair number of countries that had been certified free of malaria. And if you could see the slide, about that time, there were only two African countries, Morocco and Algeria. Okay, thank you very much. So we had only Morocco and Algeria from our continent that had been certified free. But since we started in 2020 with the new group, we've added about 5 countries so far, and in those 5 we have all, I think there was no African country, but we have Cabo Verde and Egypt that are undergoing the reviews now. So maybe something will happen and we will get many more people onto the register. But the import of the register is that we are documenting progress that is being made. And there is no reason why we should not be part of this list. In fact, I'm always so happy China has been able to eliminate malaria with the current tools. China is a population of 1.4 billion people. It's done this. And it had all the kinds of malaria we can talk about, from falciparum, vivax, name it. So at the moment, this is how the picture looks like in the world. The red is the bad place. So it's between Brazil and the rest of Africa, life is really not so nice. If we focus on Africa, this is what it looks like. Some of the eastern borders are not as with high transmission as West Africa and Central Africa. If you take Nigeria and DRC Congo, you cover all the malaria you have in the world. So anyway, so this has been the good news. But the other part of the good news is that WHO in 2015 developed a global technical strategy which was take us from 2016 to 2030. And this was launched in 2016. All countries in Africa signed on to this. And we all agreed to work towards the goal of malaria elimination, regardless of the intensity of transmission. This is so important. And this policy stands on 3 pillars. And most of you know about these pillars already. The first one is, pillar 1 is to ensure universal access to malaria prevention, diagnosis, and treatment. The second pillar has to do with accelerate efforts towards elimination and attainment of malaria-free status. And the third one is the key here today that we're talking to this group, is to transform malaria surveillance into a core intervention. And I'm going to dwell much more on this. And it has the baseline having supporting elements that include harnessing the innovation and expanding research. It also has strengthening the enabling environment, including capacity development to achieve these goals. So this cartoon actually tells you, breaks down the house you've seen into the packages that are involved in the global malaria, global technical strategy. And this is available, you can always find this. What this cartoon tells us is that now malaria business is everybody's business. It has nothing to do with transmission. In fact, to put it blindly, we don't have malaria control anymore. We are heading to eliminate malaria, and the two are different. If you are opposed in the control system, you will be working in the old style that we do. Okay, I've sent a few bed nets, I'm treating people, so that's fine. The number of children who are dying is small and so on. No, that is forever. There's no time limit for malaria control. So the world decided that we will get rid of this parasite and make our people free. But most countries never actually read this very well. This has been there since 2016. And one of the key principles that helps to look at this very closely is that every country, including high-burden countries, may consider malaria elimination as a goal and adjust interventions so as to accelerate across the transmission continuum from control to elimination. And we will come back to that also very soon. That means that you don't just continue to run your malaria control program the way you've been running it. You're supposed to get your country stratified by certain basic things, and most of you are here, have been involved in this. And you need to send the appropriate interventions based on the level of transmission in the country. Because in malaria, we all agree that the transmission is not the same from one place to the other. The second point is that any country may set sub-national elimination targets as internal milestones to maintain the public political commitment, because elimination has to have a public political commitment. And the good news is that the African Leaders Malaria Alliance endorsed this. Some work is being done very quickly. They endorsed it in July 2016 in Kigali, in a meeting they held in Kigali. And some work is going on. In Southern Africa, we have something called the Elimination 8. I don't know whether some of you have heard about it, but I'm sure our colleagues from South Africa, the southern part of Africa, know about this. This involves Angola, Botswana, Mozambique, Namibia, South Africa, Swaziland, Zambia, and Zimbabwe. Are working together to see if they can eliminate malaria in the southern part of the continent. And this is how it looks like. The first group of countries that they are hoping to make sure they can eliminate malaria are in Namibia, Botswana, Swaziland, South Africa, and Lesotho. And then phase 2 will come to Angola, Zambia, Zimbabwe, and Mozambique. There is another program which is being driven in the Sahel region, which we call Malaria Elimination in Sahel 7. 7 countries in the Sahel region are also trying to put their acts together to try and pool common forces to eliminate malaria. So they are the Gambia, Senegal. I mean, if you call Gambia, you have to call Senegal. Or Senegal, you have to call Gambia. Mauritania, Cape Verde, Mali, Chad, and Niger. At the moment, there's a team heading to Cabo Verde, Cape Verde, to check whether they can be certified for that malaria is free. But having said that, I will jump straight to what I think are the main challenges. The main challenges for us in Africa, from my point of view, and from the work I've done in Asia, are the health systems. How do we modify our health systems? First of all, how many countries here have changed the names of their control programs? You see, we are still in the control mode. Most countries in Africa are still controlling malaria. That's number one. That alone makes a lot of difference as to where we are going next. Then the way in which we drive this is to bring everybody together. And I don't know how emphatic I can be about this. The ministries of health of any country alone cannot eliminate malaria. It's a national activity. You all know about how malaria is transmitted. So the Ministry of Health with the health centers and the hospitals and so on are just doing a tiny part of the way we can control, eliminate this disease. They are not, in fact, in most countries where we have been certified free, different people, different parts of the economy are the ones who are driving this. So we need to look at the national management and agenda. We need to develop great intersectoral collaboration. We need to plan at the national level and also at the local level. And the biggest challenge we face in malaria elimination is the private sector. We pay lip service to the private sector integration, and the malaria bag will always be happy when you do that. Because most of your people go to the private sector, the information from the private sector is not integrated into the public sector, and you are making many advances and showing capable changes in the malaria transmission. Finally, we have to look at finance and resource management. This must also be decentralized. It's not one person sitting in the headquarters as the control manager who is controlling all the resources. The resources must be dependent on what level that district or region is undertaking. Finally, there are a couple of more blocks, and that is the one I'm going to work on today. Surveillance as an intervention, because I think this is the right crowd. The issue of case management, drug sensitivity testing, entomological surveillance are all important. In fact, case management, we don't need to talk about it because we all know that's the first thing we all do. Then we have to look at innovation and research, social behavior, implementation strategies, and development of new tools. But having said that, let's remember that countries are eliminating malaria with the current tools. So it's not that it's impossible to do that. Yes, we may get new tools like the vaccines, and many people are excited about the vaccines, but they alone will not do that because, as we've all learned from the COVID, the new vaccines are out. We now have 2 vaccines, but they are all blood stage vaccines. They do not block transmission. So you can still get a vaccine and you can still be infected, and that's not what we are looking for. Now, how do we move this forward? Setting up national coordinating committees. And this is, it looks so easy, we say it every time, but there must be country ownership. If the country is not owning it and it's not leading it, please, you're not going to get anywhere. I've talked about mobilizing local funding, which is critical, and in the elimination exercise, it's not only commodities. You have to have more staff that are involved in the malaria elimination. Then we have to establish a functional, operational elimination committee or task force, I don't know the way you want to call it. But this must be multi-sectorial, and they will all have to contribute towards the elimination effort. And in most countries, the leadership has always been outside the Ministry of Health. So the Prime Minister or the Vice President, whatever you have, who can give instructions to the ministries of local government, education, finance, name it. Every ministry is a partner in this business. They have to budget for what they're going to do in malaria, and they have to get that direct funding. The Ministry of Health no country will agree to take its small resources and fund the other ministries. And so we come to meet, we talk, and that's the end. Nothing happens. This is very, very important. These committees that are formed must also be replicated at the district level. I'll give you an example. In China, they had a big multi-sector collaboration, and they had 11 people around the table. I don't know whether you can read it, but it was under the National Development and Reform Commission, not under the Ministry of Health. Ministry of Health was one of the partners. There, it had the Finance Department, the General Administration of Customs, the Education sectors, the Commerce Department, the Culture and Tourism Departments, the Migration Department, the Radio and Television Administration, Science and Technology Departments, Industry and Information, and the Military Health Department. And I remember very well when we went to China, I asked the question, so with this group, which agency takes the lead? Because you can't have everybody in front. And I was surprised to be told that the Customs Department was taking the lead. And Customs, what has Customs got to do with this? And the answer was simple. In every country, the Customs Department is always has money. Okay? So if they are in the lead, they always have money. If your Customs Department doesn't have money, your country is dead. So that's why the Customs Department had the lead. And they had set up mechanisms to make sure that the agenda that is set up is they take this seriously. So let's go fast again. This is also one of the provinces in China. I'm just showing you the cartoon that shows how the local groups also have the same kind of setup. So it's not Ministry of Health that is playing this business. Every level, you have to have that collaboration between everybody. And that is our biggest challenge in Africa. And when you add money to it, then we seriously are going to have a long way to go. Now, the next pillar under the human resource, under the health systems, is the human resources. In Uzbekistan, a country about the same size of Ghana, 30 million people, had almost 200 entomologists. We're doing transmission. We're trying to eliminate a disease by transmission. In Ghana today, officially, I'm sure there are less than 5 entomologists. Correct? So if you don't have entomologists in every district or region, looking at the transmission spots and clearing those transmission spots, there's a problem. Secondly, you must look at data scientists. Today, IT and analytic skills are important for every sphere of our lives, and we better wake up and start changing the people who are engaged in doing things like this. Health promotion or community engagement specialists, very big on this, because when you get to elimination phase, you wake up one morning and they will knock your door and say, your neighbor got malaria, so we are coming to test you. And you can imagine the dialogue that will start. I don't have malaria. Why do you want to test my family? So we need all these people to promote this whole process, because the process includes getting rid of the parasite before people get sick. Then the private sector enhances. The private sector provides most of the treatment in most countries for malaria, especially in the urban areas and even the rural areas. So you need to get their data into the system. You need to find ways in which you can help them fundraise. And when you are doing your training in your districts, they are part of it. They are not just a token. Otherwise, you're not going to really get anywhere. So in summary, the health system needs such that it is stratified at the subnational level, and the financial and fiscal resources must be decentralized also. Malaria control managers are now custodians of finding out what they can do to help districts achieve their goals. And private sector performance, training, data, finance, and all that must be, we have to be on top of that. There is no more one strategy fits all, that your country, this is our strategy, and that's what we are doing. No, depends on the transmission in your country. You will follow those rules that you set up for yourself, and you will monitor that from time to time. So malaria control commodities may be the main thrust in high transmission areas, while you need more people in the low transmission areas that will go to screen people and treat them before they get sick. Okay, and we all know the problems with trying to get to people who are not ill. I think COVID has been able to help us to live a little bit above that. Now, as I said, the national strategy covers the whole country. It's not desirable. Management and resources must be decentralized and linked to plans and performance at the district level, supervised by the district committees. You'll be surprised that some of your districts will be able to raise money outside what government gives them, because there might be some philanthropists in those areas or businessmen who want to see this effort succeed. And I'm going to try and see whether I can get to a place and show you an example. Now let's go to surveillance as an intervention. This is really major. And that's all I'm going to dwell about. I'm not going to go into the details of the others. So you have a national health management insurance system. Please, if the private sector is part of this, they must have access to it. They may not have access to everything, but it's not zero. Since they provide information, there should be an agreement on what they can get. The NGOs want to have access to it, the hospitals, mission hospitals, and so on. So everything goes into a national database. And you can have the malaria repository as part of that, where you have your bulletins, your reports, your technical papers, and so on. But then the main specific areas will include the interventions, the community-based interventions, the population at risk, and so on and so forth. Then there are a couple of things that will go with the malaria surveillance as an intervention. You have to establish a mandatory malaria case notification. Anytime malaria is, somebody diagnoses malaria in your country, it's a notifiable disease. You all know that. I don't need to tell you much about that. And we should not restrict it onto only case-based malaria surveillance. It's everybody. Then we have to introduce the next one, case foci investigation and response. We have to map out all the possible transmission foci, and we have to monitor them over a period of time to make sure they are not creating the problems behind us. Then you know about the drug resistance, entomological surveillance, outbreak detection and response, because you are looking at your data. And then we will have to reduce transmission. There are some things in the book that are not written. In WHO, for many years, there has been a fight over mass drug administration. I'm telling you, China did most of its work through mass drug administration, and they are efficient at that. If they find the malaria is clustered here, they will come here and they will get rid of the parasite. Simple. And it makes sense to me. If there's no parasite, there will be no transmission. Mosquitoes might bite people, but you've gotten rid of the parasite. Okay? So we think that you should go back and build upon the district health information system. This is what I have had an experience with. I know other countries are having a problem. You have to have a malaria model, and you must have a malaria case-based surveillance model, which is web-based data focused on malaria. It's very, very, very easy to do. The IT people will tell you this can be done. The HMIS is free, and you can customize it to fit your country. So every district can have this, which is linked to the national level. You enter the data, you create people who have access to it, and this goes right down to the village and community level. In fact, in Asia, I used to visit some of the health centers, the village health workers, and using their mobile phones, are able to input the data into the national database of Cambodia. So you are in your office, if you have access, anytime they report malaria case, you get a page, ping, there's malaria reported somewhere, and then you will decide who will have access or not. But this is doable. It allows you to ask a few more questions. Yeah. But it also allows you to have a dashboard that every morning when you come in your district, you can know what is going on and you can deal with it. This business is no more trial and error. It's data-driven. Every case of malaria that is treated, we must know about it, and we must make sure it works. So my time is running out, but let me go add a few more highlights. Take China, had subnational verification. It was divided into 2,165 counties, 250 prefectures, and 24 provinces. In fact, most of the prefectures are bigger than each country here on the African continent. And this was coordinated very well, and today they are free of malaria. So I have to jump all these ones. And I needed to show you something that is very important. First of all, if you take, this is Senegal. Transmission in Senegal in the northern part is virtually zero. But Senegal still has a malaria control program. It is not catering for the effects of malaria in the border with Mauritania. They could easily wipe out malaria at the border between Mauritania and Senegal because virtually no transmission. The transmission is in the southern part, but it is one business. If you go to Nigeria, the same. If you go to the border with Chad, virtually no malaria. The malaria is on the Niger side and in the southeast with Cameroon. But the malaria program has one strategy for the whole country. That is not acceptable. If you go to Ghana, the same. Now we have to tailor our strategies to the transmissions in these countries. And I will just take 1 minute to show you a case of one small country in Ghana. If you want the publication, you let me know. If you look at the top right corner, there's a small dot there. That is the district. The district is called Bunkuguyoyo. I'm sure some Ghanaians even haven't heard about that district. But work that has been done in that district is eye-opening. So this is the district. A bunch of scientists went there, and those dots you see are the villages where they took data from those villages. They went ahead for 3 years, 2010, 2011, 2011, 2012, 2012, 2013, consistently for 3 years. And the maps you see at the top are when we have the rainy season. The red colored areas are where there's malaria. So in the rainy season, you seem to have malaria in the whole district. But you see the lower part is the dry season, and most of the upper parts are what? Free of malaria, and only the lower parts seem to have malaria. And even that intensity is low. So if you were to put in a measure to cut down the malaria in the dry season in these places, I'm sure in the rainy season, the color will not look the same. The point I'm trying to make is that one size will not fit all going forward. You have to base your work on the data you have. You have to get rid of the transmission and not only treat the cases. If you are treating the cases, you are back in control, and we will all end up in the same place. Okay? So, my take-home message, we have to get there now. China has done it. We will incorporate new tools to get there faster as they come up. New vaccines, new treatments, but we can get there now. We have to innovate within the health system to increase access to care. We must license all health workers to be able to treat malaria. I don't see the technical aspects of malaria treatment is dead. What is left is logistics. How do you send the malaria treatment to those who need it most? And most of you went to health institutions. Your logistics training is suspect. So we should get people who can help us to make sure that we can send these drugs to those who need it most. Ghana and Africa must rise up to this challenge. You must increase our interventions to reduce transmission, mass drug administration, insecticide-treated nets, IRS, and we must eliminate the foci. We can do that. We don't need money to do all of this. We must evaluate the health system as we evaluate other parts of the plan. We have a scorecard that does that. And most importantly, we must increase domestic funding. Adopt a credible multi-sectoral approach to eradicate malaria. And I promise you, malaria elimination is possible within our generation. Thank you.
Okay, thank you, Dr. Okay, I would like to introduce our second speaker from the Democratic Republic of the Congo. So I will introduce him in French, so I can give the French interpreter a little break this time. Okay.
The second presenter will do a work on overview of research studies conducted on pox in Democratic Republic of Congo. Dr. Placide Mbala Kangweni is a medical doctor and is working for the National Institute of Biomedical Research. And he works on diseases like Mpox and Ebola. He is actually associated in the faculty of the University of Kinshasa, the Department of Medicine. And he's also the Director of Research in the National Clinic of Biomedical. Dr. Mbale has received a prize in the training by the WHO in Berlin. Ladies and gentlemen, please clap for Dr. Mbale. Thank you very much.
Turn for your French. Yeah. Sorry, I'm going to give my presentation in English. So I'm Placide Mbala. I'm the head of epidemiology and global health department at INRB, which is the National Biomedical Research Institute in DRC. And I'm also associate professor at the University of Kinshasa. So I started my career working on Mpox. This is why I'm going to give you an overview of all of different research that we are conducting in Mpox since almost 2002. So as you know, Mpox, the first human case was identified in DRC in 1970, almost 2 years after this area, Basonkusu, was declared kind of, they eliminated smallpox. So WHO has a great concern regarding this new disease that is similar to smallpox. And so they decided to conduct an active surveillance to understand if Mpox can fill the niche, ecological niche left vacant by smallpox after the eradication of smallpox. So the active surveillance started almost in early 80s. So this is a photo of the prim that we are giving in the DRC at that time to any person that can report a case of Mpox. So you will see in most of my slides, there are sometimes monkeypox and Mpox. So as you know, monkeypox was now changed to Mpox just recently. So, and here you can see during the active surveillance of Mpox from 81 to 86, most cases reported in DRC, in other countries in Central Africa and West Africa. So then at the end of this active surveillance, this is the conclusion of WHO. So there was no evidence of an increase in the secondary attack rate between 70 AD and 81 and 86. So inefficient spread from person to person, even in condition of maximum exposure, support the concept that monkeypox virus is poorly adapted for sustained transmission between humans, and that such transmission does not pose a significant health problem. So the active surveillance stopped. There was a kind of a silence. Then boom, in 96, 97, a huge outbreak occurred in DRC, and this raised many questions. What we don't know about Mpox? What is the current burden of Mpox infection in exotic areas? The risk of Mpox is if this risk changed after 1980s. What are the risk factors associated with Mpox infection? How transmissible is Mpox? And is there evidence of long-term protective immunity to Mpox from previous smallpox vaccination? So we decided to conduct several studies. The first one was this one that we conducted in collaboration with the University of California, Los Angeles, from 2002 to 2011. So we did a kind of an active surveillance in Sankuru, where the huge outbreak in 96, 97 occurred. So what we found is that, as you can see in this slide, we found an incidence of Mpox about 20 time-fold more than what was estimated by WHO from during the last active surveillance in 81, 86. And also, this incidence was higher in the forest region compared with others, like savanna and ecotone. And also regarding the long-term immunity, the analysis of our data from 2005, 2007 shows that smallpox vaccine gives about 80% of immunity, so there is no significant decline over time. And also, the challenge was how to see the impact, I can say, the contribution of zoonotic or spillover, zoonotic spillover versus human-to-human transmission. So we try to list a number of factors and then see how they can impact one transmission or the other. So among those factors, there are declining the herd immunity, which impact both transmission, increase Mpox prevalence in reservoir, increase hunting of reservoir animals, both impacts mostly the spillover, the zoonotic spillover, declining immune status due to malnutrition or co-infection that can impact both ways of transmission, virus adaptation to human, and possibility of intergenerational transmission, which impacts the human-to-human transmission. So after that, from 2008 to 2011, we decided to conduct a clinical characterization of a human monkeypox infection in almost the same area. So it was the same area where WHO conducted that active surveillance from 81, 86. So this study, we enroll more than 200 participants, and we follow those participants to collect for like 3 weeks, and we collect like almost every day clinical signs and symptoms, and also lab parameters like hematology, biochemistry, and so on. And this paper was published, so it was kind of a huge cohort that we had that time regarding the clade 1 of Mpox in the country. So we found out that during this study, regarding the exposure, most of the participants reported more than one type of exposure. So either being in touch or in direct contact with animals by cooking, say cooking, dressing, being in touch with squirrel, monkey meat, and so on, but also with individual confirmed with Mpox disease. And regarding the sign and symptom, the more prominent sign and symptom were skin lesion and lymphadenopathy that we observe in most of the participants. Most sign and symptoms last for 3 to 5 days, except some of them that last more than 5 days, like hepatomegaly, conjunctival lesion, and skin lesion, and also some lymphadenopathy. And the lymphadenopathy is the more, I can say, characteristic sign for Mpox that help us also to make the difference with other rash illness. And here, as you can see, most of them are observed at the cervical and angular region, but other regions can also be affected. And regarding the lab analysis, we try to compare a few fatal cases that we have with the survival, and what we have seen is kind of a difference in transaminase result, platelet counts, and also we observe kind of elevation, increase of protein in the urine following the severity levels. Some complications were common during our study, for example, keratitis, staphyloma in the eye, calcification of lesion in the eye, dermatitis and edema. We also show some congenital cases of Mpox with intrauterine transmission. The next study is a collaboration with the CDC to evaluate the Jynneos vaccine in healthcare worker in the country, in DRC. So this study, as you can see, has 3 parts, essentially. In 2017, when we started the study, we vaccinated 1,000 of healthcare workers with 2-dose liquid formulation with a follow-up of 2 years. In 2019, we vaccinated 600 with a lyophilized formulation with a follow-up of 2 years. And then we did the boost for the first cohort 5 years later, and a follow-up for during 14 days. So we found out that the Jynneos vaccine had provided a strong specific antibody response in participants. The peak was 4-fold higher in people with prior smallpox vaccination, but we observed that in both groups, they experienced similar increase from baseline. And there was no major adverse event where during this study. 23% of the vaccinated participants had local reaction, and 24% they have systemic reaction, but most of those reactions was resolved spontaneously within 7 days. And a total of 16 participants had been, we have kind of a death during the 2 years of follow-up, like 16 participants, but those deaths were not related to the vaccine. This was certified by a local physician, but also with the safety monitors in DRC and in the US. And there were 14 female study participants who became pregnant within 6 months of receiving the vaccine. 13 among them, they deliver healthy babies. The next and the two studies that are still ongoing, it's a collaboration between our institution and the NIH. This is in the framework of a new program that we started in 2018 during the Ebola outbreak, starting with the clinical trial to evaluate the efficacy of Ebola therapeutics. And so right now we are working on the Mpox to evaluate the antiviral, the tecovirimat efficacy for treating adults and children affected by Mpox. And we are also doing at the same time doing a safety study with the vaccine in both sites selected for our study. And this study started last year, 2022. 2 sites are selected, so the study is still ongoing. We have already enrolled about 328 participants, so we hope that by early next year, we should be able to get the preliminary results. And for the vaccine, we are following the safety of the vaccine among healthcare workers that are in the sites where we are doing our randomized controlled trial. Until now, we didn't report any severe adverse events. And there are other opportunities and other studies that are still in the pipeline that we are planning to do in near future. We are seeing how we can well characterize, for example, the clinical cohort for long-term sequelae and immunogenicity studies, how to improve also the diagnostic. As you know, it's very difficult for the moment to have a very good diagnostic for Mpox. And so we are working on it. We are also working to see how we can conduct some of the study in key population, for example, care worker, hunters, pregnant women, breastfeeding women, working on other kind of co-infection that can coexist with Mpox in some area, reinfection and reactivation of the Mpox. There are some cases that we are recording during our study, our current study, some cases of reinfection, or we don't know if it's a reinfection or a reactivation. What is the transmissibility of this disease? We know that it's a zoonotic disease with most zoonotic case than human-to-human case, but we are seeing during our outbreak in a DRC kind of a shift with less zoonotic case and more human-to-human transmission. And also we are planning to, we have already started to do some genomic study, ecologic study, and see also how to expand the surveillance and sero survey in human and animal at different geographic region. Thank you so much for your attention.
Okay, thanks to all of our speakers. In the essence of time, I will just ask if there are any questions, if you can get queued up. We probably would have like 2 to 3 minutes of questions because there's the next session. So any questions? Sir.
Fred, this may be more of a comment. I'm aware of the excellent work you're doing. Congratulations. At one time in 2019, Professor Richard Feacham said that maybe we could eliminate malaria by 2050, which looks rather far to me. And when you show us what has happened in China, I'm asking why can't we do that faster, and would it be possible? Mon ami, Monsieur le Professeur from DRC, just a question or comment. I see in the number of pictures you put some children there. What are some of the ethical issues? Could you not obliterate the eyes or something? Just a little comment. Merci beaucoup.
So thank you very much. The Lancet Commission Group estimated that we should be able to eliminate malaria in 2050, based on the estimates that they made. And there were other conditions attached to that, that we must be aiming at 80% of the current interventions in all countries. Then that will happen. The problem we have is that it might not be feasible if we are continuing at this rate. In most countries, people have not yet, the national buy-in is not there in most countries. They're waiting for resources to come from outside. And most countries that have eliminated the malaria have had to use local resources, which is then supported by external resources. And as you know, if you make the resources available like a seasonal kind of thing, then the malaria is really happy because then it comes back with a bound. So that's one of our problems. We are not yet really very fully committed.
Okay, I think we have time for one last question. Sir?
Just a comment. Thank you so much. As you know, Mpox is a skin lesion, so we normally have a consent that we provide to the participant and to the parent, and expressing clearly on the consent that the photograph will be taken and so on. For the photograph that I show here, that are my photograph that I took in the field, and it's because we wanted to show the high lesion that we cannot obliterate the high. But for example, when we take the picture for the full body, we usually try to hide the face and so on, to avoid that the participant be recognized.
Okay, thank you. My name's Sefud So from Tanzania. I want to ask one question. Being noted that malaria is the curable disease, and you have told us that elimination of either parasites or mosquito can effectively lead us to reach the 2030 goal of free malaria zone. So having noted that we have ineffective interventions due to inadequacy of funding, we have the Little Fund, which we put into different interventions. So can you recommend that we have now to focus to either MDA, because to utilize enough that money we have in MDA, or if it's on the entomology, maybe to do indoor residual spray to ensure that we are free of malaria? Can you recommend that? Thank you.
So thank you very much. First of all, it's not the elimination of the mosquito. In fact, long after you've eliminated malaria, the mosquito will be around. I think it's one of the last things that will go off the earth. There are too many mosquitoes that we shouldn't aim at trying to kill the mosquito. The mosquito is only taking the parasite. That's one. Secondly, what I was saying was that the old discussions about whether we should use MDA and so on are back, because people have found out that if there are parasites in the population, you should get rid of the parasites. So you have to determine where you want to use this. It's safer and better when the transmission is low, but other groups have used it where the transmission is high to bring down the load. So if you live in a seasonal area, you see that there are some times of the year there's not much malaria. So if we were to target it in such a way that just before the malaria season starts, there are no parasites hanging around, then transmission will go down. So it has to be tailored to the situation that you have, and it cannot be a blanket decision, but it's available, it can be used.
Okay, thank you very much to all panelists and everyone here. This concludes this session. Unfortunately, we do have an immediate session using this room. So if you have any additional questions, please feel free to meet the panelists as they exit. So thank you. Merci pour votre attention. Au revoir.
I want to make an announcement and to clarify. Our dear moderators and evaluators, that we can't have breakout sessions while we are having a plenary. Let that be very clear, because this is one of the breakout rooms. So we'll finish the plenary and then we go into concurrent sessions. So this marks the end of this session. We'll have a break of 15 minutes, and then we'll come back to our last session for today, which has to be completed within 1 hour. But just before you go, I'd like to inform all of us that we'll be having a social event this evening, starting at 7 p.m. right here, the Culture Night. It's called the Culture Night, and during this night, we will get to learn more about the Kenyan culture. You're all invited to come and be part of this event. And the dress code is a simple one. As long as you put on anything that is in line with the national, with the Kenyan national colors, and those are black, red, green, or white, anything there. Any in those colors, you'll be in sync. So to repeat, the culture nights will be in this very room, Arabuko room, starting at 7 p.m. You're all welcome. Dressed in Kenyan national flag colors. So at this point, let's break for a short break, and then reconvene by at 4. And my dear moderators and evaluators, the next session should be delivered strictly in 1 hour, because at 5, the room has to be organized for the culture night. Thank you.
That'll be we'll not be able to finish in 1 hour. So you try to save us time, go as fast as you can, so we can enjoy the cultural night. Yes? Very good. Good afternoon, everyone. The last session was pretty an exhilarating plenary session and very short and precise, and we thought we could have taken advantage of continuing, but the bosses decided to give us a break. But we're here back, and we need to move quickly so we can enjoy the cultural night today, hoping to wear Kenyan colors. So I have with me to evaluate this afternoon Dr. Peter Adewi and Banda Jezreel. We're still waiting for Banda, but we'll go ahead and start because of our time. My name is Chima Ohuabunwa, and I have the honor to moderate this session. And we'll try to keep to our time. Well, the speakers are already on stage, which is what we wanted to make sure we did, so you're comfortable with the stage. And we'll go straight on to start with the first speaker, if you're ready. Mercy Wendy Wanyana from Uganda. Welcome. Please welcome her with a clap.
Good afternoon. I am Mercy Wanyana, and I'm an advanced field epidemiology fellow, and I'll be presenting to you the performance and impact of contact tracing in the Sudan virus disease outbreaks, September 2022 to January 2023. Sudan virus disease is an Ebola disease caused by the Sudan Ebola virus. It is transmitted through human-to-human transmission by direct contact or contact with infected body fluids or contaminated fomites. In contact tracing, in Sudan virus disease outbreaks, new Sudan virus disease cases typically emerge from contacts of cases, making contact tracing a key measure for outbreak control. Contact tracing supports the timely identification of cases by identifying contacts who are potential cases and testing them before they develop symptoms, and also reduces the risk of onward transmission and transmits onward transmission chains through early removal of infected persons before they infect others. In contact tracing, contact details are obtained by case investigation teams during epidemiological case investigations. Contacts are then identified and listed by contact tracing teams. Monitoring and follow-up is initiated for listed cases who are monitored for a period of 21 days for the development of symptoms of the disease following their last exposure. Those who develop symptoms during the monitoring and follow-up process are isolated and tested, while those who do not develop symptoms complete the 21 days of monitoring and follow-up. Key performance indicators are essential for monitoring and evaluating the performance of contact tracing. These include process indicators, which assess the implementation processes of contact tracing, and outcome indicators, which assess the results of contact tracing in achieving the disease control objectives. Immediately after the identification of the first confirmed case of Sudan virus disease in Mubende district in Uganda on 20th September 2022, the Ministry of Health began implementing contact tracing. Despite its implementation, there were continued missed transmission chains that led to the spread of the disease to 8 additional districts in western and central Uganda. This highlighted the need to evaluate the performance of contact tracing. We therefore assessed the process and outcome indicators of the performance of contact tracing for the Sudan virus disease in Uganda from September 20, 2022 to January 11, 2023. We also assessed the impact of contact tracing on Sudan virus disease transmission during the outbreak. We We defined a contact as any person who had direct or indirect exposure to a confirmed or probable Sudan virus disease case or their body fluids within the past 21 days. High-risk contacts included direct contact with blood or body fluids. Medium risk included household, community, or health facility contact longer than 15 minutes. And low-risk contacts included being in the same building without direct contact. We assessed the following process indicators: the average number of contacts identified and listed per case, average monitoring and follow-up since the last contact with indicators. We assess the proportion of confirmed cases that were previously known as a contact at the time of their illness, the median time to isolation and case confirmation, and the number of persons infected. Here are our findings. A total of 3,844 contacts were listed and identified with a median age of 19 years. There was an approximately equal proportion of males and females. More contacts were listed in rural areas compared to urban areas, and this is probably because most of the cases resided in rural areas. Of the contacts identified, 40% were classified as high-risk contacts. In regards to the process indicators, we found that a mean of 22 contacts were identified and listed per case, and the mean time to initiating monitoring and follow-up was 1 day, and 97% of the contacts completed the 21 days of monitoring and follow-up. In regards to outcome indicators, 67% of the time of their confirmation as a case as shown in the black bars in the graph. This suggested gaps in the complete and accurate listing of contacts. In the epicurve shown here, shows the number of cases on the y-axis and the date of onset of symptoms on the x-axis. The cases that were previously known as a contact are shown in the blue color, while the cases that were not previously known as a contact are shown in the black color. We observed an increase in the number of confirmed cases that were previously known as a contact over the course of the outbreak, with an increase of cases in the blue color. This indicated improvements in contact tracing as the outbreak progressed. The graph here shows the time to isolation and confirmation among cases that were previously known as a contact in the blue color and those that were not previously known as a contact in the black color. Being previously known as a contact reduced the time between onset of symptoms and isolation by 2 days, and onset of symptoms to confirmation by 3 days. The graph here shows the number of persons infected by both cases that were previously known as a contact in the blue color and those that were not previously known as a contact in the blue color. The only people who infected more than two people were those that were not previously known as a contact. We further found that the cases that were previously known as a contact had an 84% lower risk of transmitting to someone else compared to cases that were not previously known as a contact. Cases that was known as a contact had a shorter time in the community and were isolated earlier in their course of infection that is characterized with lower viral loads, making them less infectious. On the other hand, cases that were not previously known as a contact spent a longer time in the community, and by the time they were isolated, most of them had developed wet symptoms such as diarrhea, vomiting, coughing, and hemorrhage, which are more infectious. We found a 40% reduced rate of infecting another person among females. In the rural setting where this outbreak occurred, Females are less likely to travel and interact with other persons outside their community, making them less infectious. In conclusion, the proportion of known contacts in this outbreak was 33%, which is below the target of 80% required for outbreak control. Despite this, contact tracing contributed to outbreak control by reducing the time the cases spent in the community before their isolation and reducing the number of people each case infected. We recommend the implementation of approaches to enhance the completeness of contact listing through community approaches such as involving local leaders. This contributed to more accurate and complete contact listing in Sierra Leone in the 2014 West Africa Ebola outbreak. Following our preliminary findings shared with the outbreak analytics pillar, the community volunteers, locally known as village health teams, were recruited to support contact tracing efforts. We acknowledge the following institutions, and those are our references. Thank you.
Thank you. Thank you. That's exact time in there. We'll go straight ahead to the next presenter, Ramatoulaye Diop from Senegal. So I'll give you a warning in 2 minutes, okay? When you have 2 minutes.
Thank you very much. Allow me to share with you the investigation of the case of the Rift Valley fever in Senegal in November 2021. This is the outline. As for introduction, we say that the Rift Valley fever is a hemorrhagic fever that is acute, and it touches all domestic animals like goats, and especially cows and also men. And we have various transmission cases that have been reported, and the consequences are very heavy in the economic sector, and all that is linked to this outbreak. And I can tell you in the world, especially in Africa, the Rift Valley fever cases are notified periodically, especially in Mauritania, that has 700 kilometers of border with Senegal. And in the border, we can see that we have cases of the Rift Valley fever. In October 2020, the cases in animals were notified, but the marking point is actually the notification of 2 human cases in a period of 1 week in the same region, in the health district of Jofia, and that's why we led this investigation for that particular case. We needed to assess the epidemiological situation of the Rift Valley fever in this health district of Gassas and Jofo, and to identify the transmission of the virus in the humans and all the environmental factors, and also to see the various risk of expansion. And now the framework, it's a Senegal that is located in West Africa. It's in the region that is called Fatick, in the central Senegal, in the Gossa and Jofo region. And the methodology that we've adopted, we had a cross-cutting descriptive methodology. The data collection started in September 2021, and the population is actually human beings and also domestic animals like the cows, the goats, and etc. So for the definition of case, those are actually the resident of Gossas and Jofo, and we started in 1st of September 2021, and they presented fever. Those are two symptoms that are being noted, and also the signs that are neurological and some hemorrhage. Those are the various signs that we've noted in a particular area, and that's why we suspected the activity of the virus. The probable cases was every suspected cases that are alive or even dead that have an epidemiological sign. And we have also data. We also have the investigation file for the Rift Valley fever, and we also had an evaluation grid for the surveillance system. And the collection procedures, we actually had various interviews with the people in the community. And when we talk about the data that were collected, we had epidemiological data, and we also collected the blood from the human beings and the animals, and we sent them to the labs, and we also we need also to do an environmental studies with the hygiene services, and also to see what was happening with the cases that were affected by mosquitoes, that especially the cases that were confirmed. For data management, we had the capture of the data. We use the Excel before doing the analysis, EP info 7. And during the study, we also got the oral consent of the participant, and the personal data were protected. There was an aspect of confidentiality. And as far as the results are concerned, we had two pastoralists, two that were 18 years old, and they presented a typical form with some pimples on the skin, and there was also the other things that we noted, because they didn't have good mosquito nets, and they used to eat meat that was not well cooked. And there was also other symptoms. There were many swollen parts in the bodies and all that, because they were not using good mosquito nets. Now, for the social demographic characteristics, we administered some questionnaires, and average age was about 25 years old. The ratio, as far as gender is concerned, it was 16.1. And in the suspected cases in Jofo, it was 34 and 79 for Gosa. And the cases we have for Jofo and Kasa, that now you can see the curve of the various suspected cases, and the cases that were confirmed are in red, and the suspected cases were in blue. And I can tell you the notification of the two confirmed cases are there in red. And we also had some tests for the human beings, and we had some that were positive to the Rift Valley fever, and 2 cases were noted. And we had one case in Jofo, and 11 cases of malaria, even in Gaza. For the animals, we had 82% of the positive to Rift Valley fever in Gaza. And I can tell you that we had some vectors, and when we looked at the mosquitoes and flies, and the surveillance system had mean performance at 58%, and the risk of expansion was very weak. And measures that we put in place, we had to help the providers, and we also avail some surveillance team, and also to sensitize the population in general. In conclusion, I can tell you that we had 2 typical cases that were very severe, and also an expansion through the animals, and the exposition that we found, it's actually through the animals of the blood of the animals, even though the transmission was not eliminated, and many people don't use mosquito nets. And we recommend that we need to revitalize the surveillance in the community, and also to strengthen the sensitization of the usage of mosquito nets that we can manage the various cases of this epidemiology. And those are the various references that we used. Thank you very much, and thanks also to all the partners.
Merci beaucoup. Thanks for leaving us.
Thank you very much to give us 1 minute. We appreciate.
Hassan Aude. Is Hassan here? Okay.
Merci, monsieur.
Thank you very much, Mr. Moderator. Dear participant, good evening. My name is Dr. Awade Hassan. I'm a physician, and I work in the surgery in the district, and in Madawa, to be more specific. I'm also part of the second cohort in the front line in Niger. I have the opportunity today to present to you the results of an investigation around the confirmed case of in Niger. We adopted the particular plan for our work, and we have the method that helped us to come up with results, a good result, and that's why we're going to have discussions, and then we'll have a conclusion that will close this work. It's very important to note that dengue fever is one of the most important viral diseases that is transmitted through the mosquito, and it's transmitted through mosquitoes to the human being that we call AIDS. And AIDS problem as far as global health is concerned, because we have 390 million cases per year, and we have 96 million symptomatic cases, and we have a lot of death, and the disease is endemic in West Africa. I can tell you that the transmission mode of the virus was detected in the 60s in Nigeria, but Niger, that is a country of West Africa and is a neighboring country to the Nigeria, this disease is not well known, and the case that we are presenting to you is the second notified case in the country. And this notification of that particular case is not actually through direct research of dengue fever. We are actually working on yellow fever, because it is very important to remind you that in Niger, the notification of yellow fever was silent, and the Ministry of Public Health, through the Department of Surveillance and Response to Outbreaks, had a commission to sensitize the health workers so that they can notify the dengue fever. The yellow fever started to be notified. And in the same vein, another case was actually noted, and we thought it was yellow fever. It was in January 2023. And in April, the Pasteur Institute of Dakar notified us that this case is positive to dengue fever. And we sent a mission, multidisciplinary mission, to do an investigation. And the main objective was to do some research for this positive case and to look for other cases so that we can treat them and to deal with them. And the mission was sent to Manzu, that is actually in the rural area of Uno, that is one of the 6 zones of Madawa. The district of Madawa is one of the districts of the region of Dawa. The region of Dawa is in the central part of Niger, and we have a border with the Algeria on the northern part, and on the southern part border Nigeria. And it's in the south of the region of Dawa that we have the village where we found the positive case. And the population And it was actually the maternal place where we found that positive case. We had the guide SIM 3 for this case. For data collection, we had desk review. We gave many questionnaires, and we also did some tests, blood tests, and we used the Excel software to calculate all the frequencies and the proportions that were accumulated. And we managed to survey 50 households, and we had 31 suspected cases, and the mean age, the average age is 25 years old, 2 to 60.
Supérieur à 15 ans, avec une proportion de plus de 80%.
That one of up to 50 years. We also assessed the use of mosquito nets. That anybody has to understand that within the surveyed population, only 36% were using mosquito nets, and among that population, only 25% was using the mosquito net. The active research with these cases enabled us to find in households a woman who was sick and presenting the same signs like those ones of dengue fever. And she had been examined and no therapeutic results were found. We found that the husband of the wife of the lady was a native of the village but was living in the capital of Niger with frequent travels to the village. And the symptoms we found was fever 80%, cephalus fever 20%. We can say that dengue fever is a new phenomenon in Niger because before that case there, no native person had been found to have this disease. In 2022, Niger had notified a first positive case, but was a case imported from a traveler from Cuba. The fact that the clinical signs of dengue resemble a lot to malaria, to those of malaria, the absence of diagnostic means locally and regionally, the medical centers do all possible to fight this, but you find that things are always done late. So in general, we can say that dengue is a new phenomenon in Niger, and the issues on the circulation of this virus must be asked. Distinguishing malaria and dengue sometimes causes trouble. Recommend integrated surveillance and strengthen transborder collaboration. What public health actions taken? We made a reminder of the definition of the cases among all health actors. We made an active research of the cases, and we made sensitization campaigns of population, and we had blood tests. We took and want to strengthen surveillance, dengue surveillance in all the areas we are working in. I thank you very much.
Thank you very much. Good timing. Again, we'll proceed, so we'll try and save this time to the next presenter. But we'll make a rule that we'll have our questions at the end. And if you have to ask a question to a French speaker, you have to ask it in French. Just kidding, I'm joking. Next presenter, please. We'll have François Dadje. Yes.
Chers membres du jury, chers confrères.
Dear members of the jury and dear participants, I'm called François Dadje. I come from Benin. I'm going to present you the profile, the epidemiological profile of the Lassa virus fever. So this is the plan I'm going to follow. Introduction, then I'll talk to you about the study method. I'll talk to you about the results, after which we shall discuss. The Lassa fever is a hemorrhagic viral fever, which is due to the Lassa virus. It belongs to viral infections categorized as common constant fever of the hemorrhagic syndrome. We can call this This disease causes vomiting, nausea, and the incubation is between 6 to 21 days. The main signs are vomiting, nausea, and stomach pains, and so on and so forth. 80% of the people, the contaminated people, are asymptomatic. The fatality level is 1%. In Benin, between 2014 and 2016, we had more than 70 suspected cases. So we proposed to analyze the data, the surveillance data of this fever in order to propose solutions for the improvement of prevention and treatment. Objectives of our study: to analyze data of Lassa surveillance in the department of Bogu, and specifically to define tendencies of the Lassa fever and determine the incidence and fatality of the disease per year and per commune. We undertook a descriptive study of the data of Lassa fever surveillance from the year 2016 to 2021, and the cases registered in Bogu from 2016 to 2021. Bogu is one of the 12 administrative departments in Benin, in the north of the country, where we have with an area of 6,000 square kilometers. Our sampling of the cases registered in Gogu from 2016 to 2021 are the ones I've been projecting here. The data were extracted from the base of SMIR, and we made an analysis with AP-M4 and Excel, and we created proportions and frequencies. Results. So we obtained the results I'm going to propose to project now. In total, 64 suspected cases were registered. Of the 60 cases, 36.67% were confirmed in the laboratory. The gender ratio was 1. We noted that the age bracket, the most touched age bracket, was between 20 and 29 years of age in a population of 35%. And lethality was of 31.66%. So let us try to see how the disease behaves during the year. According to the months, we noted that every year the disease appears mainly between October and April of the following year. And that behavior was observed 2016, 2017, 2018, 2019, 2021, 2020, and 2021. We tried to calculate the cumulative incidence, and we noted that for 1 million inhabitants, there were 2 communes of the department, that is in Paru Chauru, which manifested the highest accumulated or cumulative incidence results. In the discussion, we found that 50% were women. Jibo and Cravateur, we found a ratio of 2/3, and the age bracket concerned was between 20 to 30 years of age, which is a proportion of 35%. in the commune of Chauru, which was the most represented, had a proportion of 63.33%. The lethality in that administrative department was of 31.6%. In the most touched commune, it was of 42.1%. Dr. Kilema Gilele and others in 2016 had found a proportion of 49%. As we have noted, lethality in the administrative department of Bogo was 31.66%, against a world rate of 1% for patients that have suffered from the severe form and 15% in hospital environments. And the international department in 2012 found 1 to 2% and only 15% in hospital environment. Lepak Gofa and Emory and his collaborators found 9.3 up to 18% in endemic zones, which was obtained from hospital environment. Conclusion: this fever has got a seasonal appearance with risk highest during October to April, and it's the youth, men and women, that are all concerned, which leads us to make these recommendations. The local leaders and population and media, we must sensitize the youth in order to reduce the rate of this disease in the department and the Ministry of Health. The Ministry of Health should increase its vigilance, especially in the most difficult months, that is October to April. We thank AFENET for the chance they gave us. CDC, the Ministry of Health in our country, the Ministry of Agriculture, we thank you very much for your attention.
Thank you. Cool. That was good. We're saving some time for ourselves. So we'll continue. We will call our friend from Sierra Leone, Mr. Samuel Toure. Samuel Toure.
Thank you very much. Good afternoon to you all. My name is Samuel Toure, a National Surveillance Officer and FETP Intermediate Graduate from the Ministry of Health, Sierra Leone. I will be presenting on the epidemiological analysis of Lassa fever in Sierra Leone 2018 to 2022. My presentation will follow this outline. Starting from introduction, Lassa fever is a zoonotic hemorrhagic disease that is endemic in West Africa, including Sierra Leone. Outbreaks of Lassa fever have been reported in several districts in Sierra Leone. Despite the continued efforts to combat Lassa fever, transmission of the disease is ongoing in communities. Moreover, there is limited information on the epidemiological characteristics of Lassa fever cases. We therefore aim to estimate the magnitude, describe the distribution, and determine the incidence and case fatality rate of Lassa fever cases. To achieve those objectives, we did secondary data analysis 2018 to 2022, looking at all suspected viral hemorrhagic fever cases, and data was extracted from the National Reference Laboratory database. On the right, we have the map of Africa, wherein Sierra Leone is located in West Africa. And the arrow is pointing at the map of Sierra Leone, which comprises of 16 districts with a population of over 8 million. This is the case definition used to identify and classify cases of Lassa fever. For data analysis, we use the Microsoft Excel to clean the data and EpiInfo version 7 to analyze the data. We analyze the age, sex, and districts of occurrence. We calculated the frequency, age, the median range, incidence, proportion, and rates. and we presented our results in text, table, graph, and map. Permission was obtained from the Ministry of Health to analyze the data. Ladies and gentlemen, I will now take you through the results of our analysis. A total of 63 confirmed cases of Lassa fever were reported, with a median age of 19 years, range 1 to 82 years. Of the confirmed cases, 57% were female, and the overall case fatality rate was 63%, of which female accounted for 58%. A cumulative incidence of 1 per 100,000 population was reported. We analyzed the distribution of cases by districts. Of the 16 districts, 5 districts reported confirmed cases of Lassa fever, wherein Kenema district accounted for the highest number of cases. The color on the map is determined by the number of cases. The higher the number of cases, the darker the color on the map, which is indicated on the legend. We analyzed the incidence of Lassa fever cases by age group, wherein the age group 20 to 29 years accounted for the highest incidence, 1.4 per 100,000 population, followed by the age group 9 years below, with an incidence of 1.1 per 100,000 population. We analyzed the case fatality rates by age group, also wherein the age group 20 to 29 years accounted for 70% of case fatality rates, followed by the age group 9 years below, with a case fatality of 69%. We went further to analyze the case fatality rates among hospitalized and non-hospitalized cases. More confirmed cases were hospitalized with a case fatality of 47%, as compared to non-hospitalized cases with a high case fatality of 85%. We also analyzed the cases by months and year, as the study covers a 5-year period. So cumulatively, all cases were reported in all months during the 5-year period, with multiple peaks, and the highest peak was in January 2021. Most of the cases were found in communities bordering with Guinea and Liberia. Findings from Guinea and Liberia showed similar high incidence of fever cases among the borders with Sierra Leone. There were high case fatalities among non-hospitalized cases, and this could be due to community deaths, late detection and referral, leading to death on arrival. Lassa fever cases were reported in every month during the study period. More cases were reported in the dries, which is similar to a study done in Nigeria. However, there are limitations to our study, wherein the clinical signs and symptoms of cases were not included in the database, and also no detailed information was collected on those who died. Therefore, we could not identify high-risk group for deaths. In conclusion, 5 of the 16 districts reported Lassa fever cases under the study reviewed. Kenema district accounted for the highest number of cases, and the age group 20 to 29 years accounted for the highest incidence. The case fatality rate was highest among non-hospitalized cases. For public health action, we engaged the district with high number of cases to improve on environmental sanitation and good hygiene practices, and also on early health seeking behavior and timely referral of all suspected cases to reduce death. We also sensitized clinicians to improve on case management and reduce the case fatality rate. We therefore recommend the Ministry of Health to conduct further research on the high-risk group in the population, and to also improve community sensitization on early health seeking behavior for timely intervention. Also, to intensify community-based surveillance in communities along the borders with Guinea and Liberia. These are our references. I acknowledge the following institutions. Thank you all.
Thank you, my friend. Thank you very much. Please have your seat. Yeah, we have the mandate to deliver this hall by 5 p.m., and I think we will get a prize if we do. So we'll go straight ahead to make sure we get our prize and call on Rebecca Akunziwe. Rebecca, please.
Good afternoon. My name is Rebecca Akunzire, an Advanced Field Epidemiology Fellow, and I'll be presenting time to isolation and associated factors among Sudan virus disease patients in Uganda, September to November 2022. Sudan virus disease, formerly known as Sudan Ebola virus, is a viral hemorrhagic fever caused by the Sudan Ebola virus. The overall case fatality rate across outbreaks has been 40 to 60%. It has a high transmissibility through direct contact with blood or body fluids of a patient or body of a deceased SVD patient, or indirectly through infectious droplets or fluids on clothing, medical equipment, or other surfaces. SVD infectiousness increases over time during the course of the illness. Early isolation of SVD patients at Ebola treatment units, ETUs, that is if it is within 2 days of symptom onset, is crucial to disrupting the transmission chain, as shown in the following illustration. Case patient A is isolated late and as such infects patients B and C. B is also isolated late and infects patients D, E, and F. However, C is isolated early and does not infect other patients. This is why contact tracing is crucial, because it identifies persons who have been in contact with an SVD patient, ideally before symptoms develop. This is why knowing which persons were contact of an SVD patient is crucial to outbreak responders. ETU isolation requires active case finding and contact tracing. It also requires that health workers have a high index of suspicion for Ebola disease and refer suspect patients. Active case finding and follow-up of contacts may not identify all cases, which is why the health-seeking behavior of patients with Ebola disease is an important determinant for outbreak control. Our objectives were to determine the time taken to ETU isolation among SVD patients in Uganda from September to November 2022, determine predictors for delayed ETU isolation, and explore the influencing factors. This was a mixed method study, and first, I'll present the quantitative component. We used a retrospective cohort study design. The population was all confirmed SVD patients during the period September 20 to November 30. That was the period from declaration of the outbreak to the last known SVD patient. We chose to start our study on September 20 because before this, there were no functioning ETUs in Uganda, and thus SVD patients could not have received ETU isolation. We included patients from all affected districts. The affected districts are shown on the map of Uganda on right and are highlighted in yellow. We abstracted data from the Ministry of Health line list on demographic variables, that is age, sex, district of residence. On clinical variables, that is date of onset, date of ETU isolation, time of symptom onset relative to the outbreak timeline. We chose October 15, the date of lockdown institution, as the cutoff. We categorized patients with onset before October 15 as occurring earlier in the outbreak, and those October 15 or later as later in the outbreak. Whether or not the SVD patient was listed as a contact of another patient before symptom onset. Remember, this is useful because it helps identify patients early in their onset, and thus is a useful metric for We calculated delays from patient symptom onset to ETU isolation as says, from symptom onset to isolation at an ETU. We categorized the time as within 2 days of onset and called it rapid isolation, or greater than 2 days of onset and called it delayed isolation. We performed descriptive and modified Poisson regression analysis to examine the effect of different factors on delayed isolation. Of the 142 confirmed SVD patients, we excluded 24. 23 with dates of onset before September 20 and 1 fetal death, leaving us with 118 patients. I will now present the results. Almost 2/3 of patients were 18 to 40 years old and male. The vast majority were from Mubende, Kasanda, or Kampala districts. The pie chart shows the percentage of patients who were identified as contacts before experiencing symptoms. The orange portion represents those not listed as contacts before onset, while the blue represents those who are listed as contacts. Most, that is 62%, were not listed as contacts before they developed symptoms. This is an epicurve for Ebola disease in Uganda. On the x-axis is the week of symptom onset, and on the y-axis is the number of cases. There is an increase in the number of cases in the earlier period and a decrease in the later period. The overall median time from symptom onset to isolation at an ETU was 5 days. This is a graph showing the percentage of SVD patients that got ETU isolation within specified time points. Remember, anything above 2 days of ETU isolation is delayed. 78% had delayed ETU isolation. The figure shows the median time from symptom onset to ETU isolation. The y-axis is the time to isolation in days, and on the x-axis is the week of symptom onset. The shaded region represents the limits of the first and third quartile of time to ETU isolation for patients who had onset during that week. Generally, the time to ETU isolation decreased over the course of the outbreak. Shortening time to isolation means the ability to control disease spread. We looked at factors associated with delayed isolation, and we found that age, sex, and being listed as a contact before onset were irrelevant. However, having onset earlier in the outbreak was associated with increased risk of delayed isolation compared to later in the outbreak. This likely reflects improved awareness among the general and healthcare community about the outbreak. Having looked at factors associated with delayed ETU isolation, we conducted a qualitative study to examine why isolation was delayed for some patients. We conducted in-depth interviews in Kasanda district, which had active cases at the time of our investigation. The picture shows me conducting an in-depth interview with a survivor. We achieved saturation at 17 interviews. 3 major themes emerged as facilitators of rapid isolation. Participants noted that knowing SVD symptoms before their onset shortened their delay to ETU isolation. They reported having received this information from health workers. A participant noted, "It is the signs they told us that made me think Ebola, that if you begin to get a fever or get dizziness." Interview participants explained that knowing that they were a contact of a confirmed SVD patient was a major reason for rapid isolation. A participant noted, "The day I was told I was one of the contacts of the late ex who had died of Ebola, it came in my mind. The guy I was staying with had died of Ebola. It never took me time to resist like other people." Despite expressing fears about care seeking, participants with rapid isolation reported that encouragement from a trusted source encouraged them to seek ETU care early. A participant noted, "The doctor who I know, he told me to go to the hospital and you'll be treated. And I asked him, they told us they kill people. He said, no, you go. I'm your friend and have sent you there. That is why I got the strength and went." 2 main themes emerged as barriers to ETU isolation. The health workers had a low index of suspicion for SVD as a possible diagnosis, even in this outbreak setting, and as such, treated patients for other illnesses. A participant reported, "So I was admitted at the clinic and was being treated for typhoid with medicine through the vein for 4 days, but when it, that is typhoid, refused to heal, the health worker told me that the dose is over, but you are not improving, go to the ETU." Fear of what takes place inside the ETU was reported in nearly all interviews. When fear was reported in the narrative, it was also in the context of lack of referral by health workers. The fears were related to a lack of food in the ETU, rumors regarding organ harvesting, among others. A participant noted, patients would call here and tell people at home there is hunger, they don't eat, that they inject them and take their body parts. In conclusion, most cases were isolated late after symptom onset during the SVD outbreak in Uganda. Early isolation is critical for outbreak control, and without it, Sudan virus can spread unchecked. However, delays to ETU isolation reduced as the outbreak progressed, and this is likely one of the critical factors that led to the end of the outbreak. Importantly, several modifiable factors that could be incorporated into the response, including knowing SVD symptoms, knowing that one was a contact, and encouragement from a trusted source were facilitators of rapid isolation, while challenges with healthcare workers thinking Ebola first delayed isolation. Ministries of health could consider the following in future outbreaks. 1, strengthening contact tracing, especially early in the outbreak, to enable rapid isolation. Awareness campaigns for communities, incorporating trusted community members in the response. Refresher trainings for health workers in the public, private, and informal health sectors to enable health workers think Ebola first. The picture on the left shows a dissemination meeting with the risk communication team and VHT. Following this dissemination, we with the response teams organize visits with the community members to the ETU as shown in the picture on the right. Thank you. I acknowledge the following institutions, and these are the references.
Thank you very much, and merci beaucoup. Well, we are doing very well with our time. We have gone from Uganda and back to Uganda. We have crossed Ebola. We have gone to Lassa. Who knows Lassa is a city too? Lassa is a city in Nigeria, and Ebola is a river in DRC. Yes, and the Deputy Director General said we should not have boundaries, that we are one people. And you can see Ebola went from Uganda, from DRC, well, Uganda is in their border so they can share, but came all the way back to West Africa. And now Lassa is moving. So we need to truly work together and address these things as one, as a region. It was a political statement, but it has very good, it has key implication for disease control and for us. And I think as we leave, we should keep thinking how we can strengthen our regional collaboration in disease control. There's a new species of Ebola that has just been identified. Who knows what country it was identified from? Because you know where the latest species, the 6th species of Ebola. Right? Where's my Sierra Leone friend? You forgot? You know a place called Bombali? Yes, that's the latest Ebola species. It's called Bombali Ebola species, added to the rest and the rest of it. So it's increasing the number of diseases species identified. And another good news, before I let you ask your question, is that during the Ebola surge of 2014, the 2014 West African Ebola, one of the good things that came out is that we now have at least a vaccine for not the Sudan, but the Zaire species. And when the Sudan occurred in Uganda recently, we were left hanging again because the vaccine we discovered from the Zaire outbreaks in West Africa and DRC could not help us. So telling us we need to do more work, and we will do more work. So we're going to give some time for quick questions for our wonderful presenters. We have, I think, about 10 minutes to do questions. If we can save more time, that would be great. So the mics are open. You go to the mics and line up if you have questions, and then we'll take all the questions, and then the presenters will respond according to the order of sitting. Thank you. Let's see. So you just ask your questions as you come to according to the time you get to the mic. So the first person, go ahead over there.
Thank you. Thank you. My name is Salomon Coville. I'm working for AFENET. My question goes to the Sierra Leone one who presented on Lassa fever. All the data quality, including the completeness of the data, can affect your analysis. Because it's something that you mentioned about data quality, but you still have some areas most affected, then all data quality can affect this. The second question for him is, this Sierra Leone collect data on environmental survey when you have an outbreak, Lassa fever. It could be very good and then to do a comparison of data, environmental data and surveillance data, and then to see where you have more risk, taking into account the environmental data for Lassa fever. Over.
Good evening. I'm Paul S. Mansayo from Sierra Leone. My question is for the Uganda presenter. I just want to know what was the method used for your sample collection for the qualitative method, and also you only consider knowledge level as one of the factors affecting delay in ET isolation. Are there other factors that might have contributed to the ETU isolation that might have contributed to the delay in ET isolation? I thank you all.
Merci, bonsoir. Je suis Dr Moussa du Niger. Ma question est pour le présentateur de Sierra Leone.
Of Sierra Leone.
Dans votre
In your
présentation,
presentation, you've talked about the limitation in your studies, the limitations. You talk about limitations in the sense that there are some data that are missing, some variables that are not input in the base. For example, the sites for the clinics and also for the death cases. And in terms of actions and recommendations, you did not say something to sort out that issue. So I would like to understand. Thank you. Good evening. I come from Benin. My name is Lau. I would like to ask my question to Mr. Adidja. The tendency for Lassa fever, the young people are most affected by that infection. So I would like to know if that particular period has actually an economic activity that is of interest to the young people. And if that's the case, can you give us some recommendations? All right.
So we're going to want to give our presenters good time to answer the questions.
Good evening. My name is Alex. I'm from Nigeria. I have a question for the presenter that presented on Lassa fever. So I was quite concerned about the high case fatality rate because you detected 63%. So, and I was more concerned because he said it was more of the case fatalities came out from non-hospitalized patients. So I was wondering where you got the data from for these non-hospitalized patients. If they were tested for Lassa fever, confirmed to be Lassa fever, why weren't they admitted in the hospital? Why acid? So in other words, I do believe that one of the reasons for this high case fatality rates was that there was poor surveillance, there was poor contact tracing and poor follow-up. But why weren't they admitted to a hospital if they were confirmed to be Lassa fever cases?
Okay, that should be our last question now.
Good evening, everyone. I am Aboubakar Amadou. I am an environmentalist, and I come from Niger. My question is asked to the representative of Senegal. So I would like to know the different environmental factors that actually favor the emergence of Rift Valley fever in your area of study. Thank you.
His question also reminded me to say what one of the things I wanted to mention Rift Valley fever we thought was for the Maasais and people in the east. Now we're getting it in Senegal. So we need to work together. Let me emphasize that again. So most of the questions I see came to Samuel, I think, from Sierra Leone, and he's sitting right here beside me. So let us start with him. Dr. Samuel, now your turn. All right.
Thank you very much for your questions and comments. I know you were attentively paying attention to my presentation. To start with the data quality. The issue of data quality, the Lassa fever cases in Sierra Leone is embedded in the AVHF priority diseases reported in the IDSR. They can only be screened or identified when, after all investigations have been done, then specimens are now collected and sent to laboratory for confirmation. And the data we analyze, we extracted the data, as I said earlier, from the reference laboratory database. So it's because of that that some of the variables, we are not captured in the laboratory. And also for the environmental survey, somebody spoke about environmental survey for Lassa fever. So as I said, Lassa fever is a zoonotic disease. But taking into consideration the viral hemorrhagic fever cases, which is also embedded in the IDSR reporting system, to do environmental survey on Lassa fever, it's a bit difficult, wherein the testing capacity, we only have the reference laboratory in one district at Kenema, wherein it will be very difficult to collect samples and do screening for those cases. But, however, your comments has been taken into consideration. We will forward it to authorities. And for the limitations, to the data analyzed, because we could not identify the high-risk group, the cases were not classified whether they are pregnant women or they are farmers, or, as I said, the data we extracted was from the reference laboratory database, wherein if we go into the IDSR reporting tool, we only capture AVHF diseases, which comprises of not only Lassa fever, but Ebola and Marburg as well. So coming to the last question, about the 63% of non-hospitalized cases. As I said earlier, Lassa fever cases, normally deaths occur in communities. And those that are brought to the hospital, they arrive dead on arrival. But notwithstanding, specimens are collected and sent to laboratory for confirmation. So if somebody died on arrival, we don't consider those cases to be admitted into the hospital. Whereas those admitted into the hospital and screened, then confirmed for Lassa fever, we consider them hospitalized cases. So that is why we realize that the non-hospitalized cases have a high case fatality as compared to the hospitalized, because they die on arrival, cases are detected late, and referrals also are being done late. So I hope your question is answered. If there is more to it, we can clarify it after the session. Thank you.
Thank you very much. Merci. The next
Thank you.
seated. If you have a question, you can go ahead and answer them.
Ok, merci beaucoup.
Thank you very much.
Merci beaucoup.
Thank you very much.
Il a été demandé,
It
vu la
was
tendance
asked
saisonnière de la
with
fièvre
the
Lassa,
tendency of the season of Lassa fever, the relationship with the young people in terms of activity, economic activities. I can say yes, there's a relationship when we talk about from October to April that we have the higher tendency. And curiously, it's actually the dry season in our country. It's actually the season where the young people in the rural areas, after the harvest, they do some hunting. So basically, they are most of the time with rats, mice. I'd like to add one thing. We also participated in that activities when we were young, and when we've done that study about Lassa fever, when we look back, we said, oh, we would have been affected by that. We are really lucky not to have gotten that virus, and that's why we've said this age group needs to be sensitized so that we can limit the contact. And it's very important for the whole population because the mice come to the kitchen, so we share the same space. We also need to take advantage to say that our African culture really make us in contact with cops, and we also need to sensitize people on that so that we can limit the contact with that. Thank you very much.
Next, please. Thank you.
Thank you. I was asked a question. So the environmental factors that favored the emergence of the Rift Valley fever in the two districts. So we know that there's a vectorial transmission of the Rift Valley fever, and there's a proliferation of mosquitoes. And we also we know that the vectorial transmission is essentially done by ILS, and also in the environmental front, we saw that the flocks were around the various estates and with domestic animals, and also with and the cases for animals were noted, observed in the month of October and also in the month of November, and there were various pool of water everywhere, and those are the three factors, environmental factors, that can explain this Rift Valley fever that is emerging in Senegal. Thank you.
Thank you very much. So the others don't have any questions? You have a question? Okay. Ugandan Ebola.
Thank you so much for your question. One of them was on the method of data collection for the qualitative. We used convenience sampling in Kasanda district, which had active cases at the time of our investigation. We did this investigation during the outbreak, and we varied. We achieved variation by age, sex, and whether they were a known contact before symptom onset. And also the other question was, did we look at other factors that would have affected time to isolation? That is a very good question, because some of these things would have been very good to know if they affected isolation. For instance, beliefs about Ebola, distance to the health facility, social economic status, among others. However, given that we did a secondary data analysis, because again this was during the outbreak, and we wanted fast responses, we could not ascertain this, but in future outbreaks it would be good to know whether these factors affect time to isolation. Thank you.
Very good, thank you. Can we give a round of applause to our presenters, please? I think it's been a very rich discussion on a spectrum of hemorrhagic diseases or hemorrhagic fevers, as we call them broadly. But one message I think we want to carry out to leave is that the control from the questions and the answers, the control of disease or elimination, as has been said throughout this, at this point, One Health approach is the way to go. Somebody asked about environmental surveillance in Lassa. Lassa there's a species of rat that act as vectors that carry the disease, the virus, to humans. So if the environmental scientists, environmental health people, they know they can, and even the animal health, they know periods when there is an increase in the breeding or the proliferation of this kind of rats in the environment. And if that is noted, if they were doing that surveillance, that can act as a sentinel. So once you see an upsurge in those species of rats, you already warn the human beings. That's an early warning sign. So let's, as we go, the new things we have learned and the challenges we have gotten, let's all put them into practice and work together as a team. Health can no longer be the responsibility of Ministry of Health as we know it. We need to bring everybody in. Thank you for sitting through. I think we managed to finish just about a couple minutes after, and the people are not here, so we're ready to release the hall. At the hall, we are asked to let you know and remind you again that 7 p.m. we all need to be back here, and make sure you wear one of the Kenyan national colors. Otherwise, you might not get in through the door. So thank you for being with us, and see you later. Bye-bye.
Mixing the best international music